Check 1, 2. Check 1, 2. Oh, it's the delay. That's what it is. No. Oh, all right, sweet. Check 1. All right, sweet. Now let's make sure everything's synced with what I'm saying. Check 1, 2. 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 You're gonna do the millisecond thing? Check 1, 2. Check 1, 2. Check 1, 2. 2. Check 1, 2. Check 1, 2. Check 1, 2. Check. Check 1, 2. Check. Oh, we got sound coming through the yeah. Check. 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 That's through the TV. We just got to turn that down. Which I thought we had that turned down. Check. 1, 2. Check. Check. 1, 2. What up? How's it going? Check. James, I can do the dotted delay though. Check, 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 check. Oh, thank you. Check. All right, there we go, Myron. Those are dead, yeah. Check. 1, 2. Check. 1, 2. Check. 1, 2. Yeah. So is the millisecond thing sweet? Here, if you want, we could do that right now, real fast. I could change the batteries for you. I appreciate it though. Check. 1, 2. 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 Hey, hey. Check. 1, 2. Check. Sweet. Thank you. We're gonna keep testing. No matter what, we're leaving it. What's that? Whatever's uploaded
There is a very large tumor in Atticus's brain. We would go to the ends of the earth for our child, and it was the obvious decision to take him to Cincinnati Children's for his cancer care. It required us to travel from Nashville to Cincinnati. Cincinnati Children's is the one that helped save Atticus's life, and we are so thankful.
I get to ask the kids beforehand or the family beforehand if they have a particular interest, a cartoon or sports or something. Did we come up with
What do you want your bandage to be?
The Flash running through.
The Flash?
Mm-hmm.
Cool, like Flash, like the cartoon Flash? Sort of like what you
Or something with lightning.
Okay, something with lightning, done deal. At the end of a case, as everyone's kind of finishing up, I'm not hovering over everybody. I can help make this dressing kind of thing. And everybody kind of gets into it. I have a whole set of pens and pencils and stuff, and we make these things. But basically, every child I've operated on, 10,000 or whatever, have gotten a unique dressing. I have fun doing it. Kids love it, parents love it. I had one, the dad was, it was a Brownie the elf, and the dad loved it so much that he couldn't take it off. He's trying not to ask, but basically he's like, can you cut out another one for me? And so if I would, I had to cut out another Brownie the elf for him. And I wouldn't call myself an artist. I totally do enjoy doing some creative things. I do draw, paint a little bit, but I like to feel like I'm giving them something that I've, spent some time on to tell them, you're not just something I've operated on. You're actually a human being, and here's a little piece of me with it. It's all really good.
When you're operating on a baby, you're the rest of their life. So if things don't go well or you have problems, it could affect the rest of their life and how they develop and grow and go out into the world. So to have the right and are surgically precise is incredibly important. Without those tools, it would be incredibly difficult, if not impossible, to do it. Dr. Stortz, Sybil Stortz, had an incredible commitment to the children of the world, and she invested huge amounts of time and money to help develop the instrumentation and to do the training that we needed to train pediatric surgeons all over the world. And I think that commitment, it is a pediatric portfolio. It goes the entire spectrum of pediatric subspecialty care. So it's a total solution.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds, it's about changing them for all kid kind. Hope, Care, Cure. Seattle Children's.
We like to use a NIM tube. That's part of trying to prevent potential injury to recurrent nerves, or at least make you aware when you're getting close to them. It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Now that we understand the standard workup and OR setup, Let's dive into the typical approach of Dr. Dialarcon's team.
It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Sometimes they can assist with the thoracoscopic approach by removing some of the residual or regrown large thymus because it's right in the way.
Did you know that State Current has an entire video library on surgical technique videos? Today, we are highlighting a laparoscopic orchiopexy. Today, we are highlighting a thoracoscopic repair of a Boschel-like hernia.
Hey, there you are. I just got the call. 5-year-old male pulled from a house fire. Vitals are listed here. What should we do first? All right, airway's intact. Breath sounds are equal and present bilaterally.
For this issue, we talked to Dr. Colin Martin. He is the publication chair and the editor of this issue.
In this case, it was
But yeah, check 1, 2. There we go. That's much better. They need to have it up here. They can't have it down here because people can't hear them. You can have it up here. Check 1, 2. Check, check 10, 9, 8, 7, 6. Keep your mic up right here. Do not put it down. Do not put it up right here. Check 1, 2. Check, 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 check. Hello, 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 hello. Hello, hello, hello. Hi. What? Oh, you want me to just keep talking? Yeah. Hi. So. Oh. So, yeah, hi. We are back. We are here in, yeah, we're good? Okay. Next one, 3.
Check, test. Mic number 3, mic number 3. Hello, check. This is mic number 3 for the 9-10 session number 1, update course 2023, and best of the best recap. This is a little bit lower for me. This is right in front of my face. This is me talking right in front of my face. Check. A little further away. Check. Test. Very close to my mouth. 9-10 session number 1, the update course. Gotcha. Here's on my mark. Keep going. Got it. Yes, this is if I'm talking a little bit louder. This is as if I'm talking a little bit and not being as quiet as I usually am and tend to be. Thank you.
All right. Number 4. I have number 4. Check 1, 2. Check. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. I'm going to go a little bit low right here. That's the lowest it should go. It shouldn't be too low like that. What's that? 1 step back? Okay, here we go. We do have tape. That was the spot where I had it, so yeah, we can move it back. Let me move it back here, but I can still talk because I can talk. Yep, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Welcome to the 14th annual Pediatric Surgery Update course, coming to you live from the beautiful in Walden at Aurora, Ohio. Why we didn't do it here last year, I think we know why. Hi, can you guys still hear me? Do you need me to still talk? All right, next. Number 5. Check. Check. You want to keep all those mics on, 2, 3, and 4?
Check. So this is going to be an audience mic, I believe. Here I am at the back of the room. Talking. Here I am if it's a foot in front of me, and I'm acting like I don't know how to use a microphone. Here it is a little bit out. Here I am at the front of the room. Check. Yep. So do I keep this one on or? Okay.
trying to see how we.
You want to move it back?
No,
Already
that's fine.
moved it back.
Yeah, it's fine.
Can you clear for me?
Yeah, that's fine.
That's fine here?
Yeah, that's perfect.
Zoom further back.
Who's on heads?
I'll probably be on that. Make sure your phones are off.
No,
Phones
sorry.
are watching.
Are you going on heads or no?
Yes. Yeah, I mean, you can run out. I got some.
Me neither. No, she's sending one to us now. What?
We're gonna have you plug this in, so you don't have to deal with a battery.
I just, yeah, that's what I, because I thought we
You got
had that
yeah,
before.
You got this. All you need to do is get an IEC for that.
I have lower thirds. What else?
No, I know the link.
Oh, yeah, yeah, you did.
Here's an IEC to your septic.
Click in the presentation.
So that's
On
one less
mine,
battery.
or?
Okay.
Yeah, on yours. That's one less battery you have to worry about.
Like, they.
If I can find more, I'll do
You
that.
can find two.
Okay, because they changed things yesterday.
They
Night.
changed it last night?
Yes, I will ask
I
them.
will try.
Okay.
Yeah, some doctors reach and then they say, oh, I used it, and I was like,
Oh, man.
okay.
Do you think they uploaded it?
They uploaded to Dropbox, but she created one completely, so we have the new things. But I will.
I did download.
Chris, you don't need a brick
something
battery.
I don't know if I have.
You'll be on.
Oh,
I have
okay.
what I had yesterday, last night.
Okay.
Okay.
I will ask Gavin and see.
No, that way we
Just so everybody knows, RA is not loading the Zoom link. I mean the whole link, but Chrome does.
Let's turn these off. So save that.
That's right.
So,
Chrome
yeah,
is-
that's for it.
Yeah, yeah, good call.
Um,
I've been using Chrome for everything.
No, I'm just, process, yeah.
Brick
And then,
Should be over there.
Myron, can
Can I send this to you?
yeah, I just need to get it back into the poll.
Myron Davis, MD, at Gmail. You get email to your computer? It's 8:10. It's 8:10, everyone. Yeah, no, you're fine. I mean, you're. Yeah, I would just grab. I'll grab a couple for you. I'll give you a spare, just in case it runs low. Might be the only reminder. Any given session, you could just either. Yep.
So I'll switch one out now. Let's put the one I have.
Who are my next two
How you
speakers?
doing? Good. Good to see you.
Hey, let's go back to
The mics are always on, do not play those.
everything is loaded. We'll click on one, click on the next. Don't we have a polls person?
Here's the mic.
Oh, Emily is doing the polls and she knows how to do it. Well, we'll have to,
Right. And then she's also doing Zoom. This is a different feed. We're gonna show.
I mean, we can, yeah, I was gonna say, show her how to swipe and make sure she feels comfortable.
So how many speakers are
Can we
there?
get the Zoom up?
Myron, how many speakers are there? Ballpark.
How many speakers would you say there are on the? Yeah. 33?
33. Yeah, so it's a challenge. We're gonna be moving.
And how will I figure out who is coming up next?
That's, well, I mean, everybody will help. Let's find somebody to help you out with that, like M.
Yeah.
And that way they're identifiable.
Copy of it? Yeah.
For the one that's gonna be used.
Yeah, I have the finished one here.
Can I take a quick look at my section?
Yeah. Do you know what section it is? They put them all in one.
Yeah, it's the
I don't know their microphone.
it was to Cincinnati Children's for his cancer care. It required us to travel from Nashville to Cincinnati. Cincinnati Children's is the one that helped save Atticus's life, and we are so thankful.
I get to ask the kids beforehand or the family beforehand if they have a particular interest, a cartoon or sports or something. Did we come up with?
What do you want your bandage to be?
The Flash running through.
The Flash?
Mm-hmm.
Cool, like Flash, like the cartoon Flash?
Or something with lightning.
Okay, something with lightning, done deal. At the end of a case, as everyone's kind of finishing up, I'm not hovering over everybody. I can help make this dressing kind of thing. And everybody kind of gets into it. I have a whole set of pens and pencils and stuff, and we make these things. But basically, every child I've operated on, 10,000 or whatever, have gotten a unique dressing. I have fun doing it. Kids love it, parents love it. I had one, the dad was, it was a Brownie the elf, and the dad loved it so much that he couldn't take it off. He's trying not to ask, but basically he's like, can you cut out another one for me? So if I went, I had to cut out another Brownie the elf for him. And I wouldn't call myself an artist. I totally do enjoy doing some creative things. I do draw, paint a little bit, but I like to feel like I'm giving them something that I've, spent some time on to tell them you're not just something I've operated on. You're actually a human being, and here's a little piece of me with it. It's all really good.
When you're operating on a baby, you're impacting the rest of their life. So if things don't go well or you have problems, it could affect the rest of their life and how they develop and grow and go out into the world. So to have the right size tools that are finely crafted and are surgically precise
I got a call from his pediatrician. He just said, "I am so sorry, but there is a very large tumor in Atticus's brain." We would go to the ends of the earth for our child, and it was the obvious decision to take him to Cincinnati Children's for his cancer care. It required us to travel from Nashville to Cincinnati. Cincinnati Children's is the one that helped save Atticus's life, and we are so thankful.
I get to ask the kids beforehand or the family beforehand if they have a particular interest, a cartoon or sports or something. Do we come up with
What do you want your
ideas?
bandage to be?
The flash running through.
The Flash? Cool, like Flash, like the cartoon Flash? Or
Something with lightning.
Okay, something with lightning, done deal. At the end of a case, as everyone's kind of finishing up, I'm not hovering over everybody. I can help make this dressing kind of thing. And everybody kind of gets into it. I have a whole set of pens and pencils and stuff, and we make these things. But basically, every child I've operated on, 10,000 or whatever, have gotten a unique dressing. I have fun doing it. Kids love it, parents love it. I had one, the dad was, it was a Brownie the Elf, and the dad loved it so much that he couldn't take it off. He's trying not to ask, but basically he's like, "Can you cut out another one for me?" So off I went, I had to cut out another Brownie the Elf for him. And I wouldn't call myself an artist. I totally do enjoy doing some creative things. I do draw, paint a little bit, but I like to feel like I'm giving them something that I've, spent some time on to tell them, you're not just something I've operated on. You're actually a human being, and here's a little piece of me with it. It's all really good.
When you're operating on a baby, you're impacting the rest of their life. So if things don't go well or you have problems, it could affect the rest of their life and how they develop and grow and go out into the world. So to have the right size tools that are finely crafted and are surgically precise is incredibly important. Without those tools, it would be incredibly difficult, if not impossible, to do it. Dr. Stortz, Sybil Stortz, had an incredible commitment to the children of the world, and she invested huge amounts of time and money to help develop the instrumentation and to do the training that we needed to train pediatric surgeons all over the world. And I think that commitment stands for a lot. It is a pediatric portfolio. It goes the entire spectrum of pediatric subspecialty care. So it's a total solution.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds, it's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
We like to use a NIM tube. That's part of trying to prevent potential injury to recurrent nerves, or at least make you aware when you're getting close to them. It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Now that we understand the standard workup and OR setup, let's dive into the typical approach of Dr. Dialarcon's team.
It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Sometimes they can assist with the thoracoscopic approach by removing some of the residual or regrown large thymus because it's right in the way.
Did you know that State Current has an entire video library on surgical technique videos? Today, we are highlighting a laparoscopic orchiopexy. Today, we are highlighting a thoracoscopic repair of a Boschel-like hernia.
Hey, there you are. I just got the call. 5-year-old male pulled from a house fire. Vitals are listed here. What should we do first? All right, airways intact. Breath sounds are equal and present bilaterally.
For this issue, we talked to Dr. Colin Martin. He is the publication chair and the editor of this issue.
In this case, it was very obviously, and it was seen on ultrasound, that there was no septum and that there was a huge cyst.
Hey, pediatric surgery. So here's another article that you probably want to know about.
The authors here wanted to take a look at preventive fundoplication for patients undergoing repair for a congenital diaphragmatic hernia.
We don't have much time, so let's start.
In this study, the authors reviewed their experience with laparoscopic common bile duct exploration with balloon sphincteroplasty for patients with pediatric choledocholithiasis. This was a retrospective review at their institution between 2018 and 2021.
For more than 65 years, Oishei Children's Hospital has specialized in the surgical care of newborns, children, adolescents, and young adults. Oishei is the only hospital in Western New York with 24/7 access to pediatric surgical subspecialties.
That includes pediatric plastic surgery, ENT surgery, ophthalmology surgery, oral maxillofacial surgery and pediatric dentistry, general surgery, thoracic surgery, orthopedic surgery, neurosurgery, and pediatric urology.
We treat all children for most common problems, such as trauma. Cancer is a problem, but we provide a full sort of spectrum of care for that. Birth is a happy occasion, but sometimes some babies are born with challenges, and we help to fix that. And then there are other things, common things like appendix hernias and so on, other things that we do.
Personalized and specific care for kids. Our chief of pediatric surgery here, for example, helped design the instruments that are used in neonatal minimally invasive surgery. We pride ourselves in being an advanced center in that regard. Even some of the most complex, technically demanding, minimally invasive surgeries there are, in which many pediatric surgeons won't even attempt, we're able to do successfully and do them in a way that patients do recover quicker.
Oishei Children's Hospital is located on the Buffalo Niagara Medical Campus, along with Kaleida Health's Buffalo General Medical Center and Gates Vascular Institute, the Jacobs School of Medicine and Biomedical Sciences at the University at Buffalo, and the Roswell Park Comprehensive Cancer Center, an Oishei partner through the Roswell Park Oishei Children's Hospital Cancer and Blood Disorders Program.
We are intimately connected to sort of a network of a sort of a next level of acuity hospitals. So see it as your high-end community hospital.
That helps kids be able to have complex care closer to home, where they have family support systems, friends who can come and visit them, and helps them feel better and recover from surgery quicker.
We also have a pediatric surgery fellowship, which is a very high-level subspecialization within the world of general surgery. There's only 30 programs in the US that have fellowships, so it's an incredible privilege and opportunity for us to have this role in training the future of pediatric surgery. The goal is to create the next generation of expert surgeons. The footprint of being close to these other medical facilities and a medical school is a big strength, and the hospital has been very committed at growing all the different service lines and specialties and maintaining a high level of subspecialties. We have a really nice outpatient clinic where we often will meet families, parents, patients, and go through the process of how we do the procedures, how the day of the OR will unfold, try to minimize the anxiety that is almost certainly associated with those stressful moments. And I work with a very dedicated group of nurse practitioners and physician assistants who are very passionate as well and make our parents and patients feel very comfortable. Our goal is to have them be able to get back to full health and energy, being able to get back to school, to the playground, hanging out with friends, doing all the sports and activities. That's always our goal, and the wonderful task and mission that we have as children is that everybody is dedicated to those goals.
OSHI is here 24/7, 365, ready to ensure that any child needing our services gets the best care. We work from the minute they arrive here to the minute they leave to make sure they can get back to being kids.
Welcome to Ann and Robert H. Lurie Children's Hospital of Chicago. Every aspect of our 23-story, state-of-the-art hospital was designed with kids in mind. An extraordinary place for healing. The second floor is also home to our Emergency Care Center, a state-of-the-art emergency room that sees more than 60,000 patients each year. Floors 3 through 8 are reserved for outpatient clinics, diagnostic testing, and procedural care. This includes our Chicago Institute for Fetal Health, one of only a few comprehensive fetal centers in the country, dedicated to the care of pregnant women with fetal complications. And our modern surgical suites, where we perform more pediatric operations than any other pediatric hospital in the state, using the most advanced techniques and minimally invasive approaches. As a tertiary and quaternary care hospital, Lurie Children's intensive care units care for the most critically ill and injured children and serve as a referral center for the community's hospitals whose patients require specialized, life-saving care. Our Center for Cancer and Blood Disorders offers the most comprehensive cancer care in the region. The space was designed to evolve to accommodate new technology and include special features to ensure the safety of our immunocompromised patients. On the top floor, you'll find our Cardiac Care Unit, one of the only pediatric units of its kind in the country. The enhanced model of care combines the technology and expertise of intensive care with pediatric pediatric cardiology to provide patients highly specialized care in the same unit for the duration of their hospital stay. This incredible building is one small reason Lurie Children's is the top pediatric hospital in Illinois, but it's the people inside that make it a truly special place for kids.
Hi, I'm Todd Ponsky, founder of GlobalCast MD, and today I want to talk to you about a significant challenge that every clinician faces. Keeping up with the rapid pace of new research. Every day, new studies are published, new techniques are developed, and new guidelines are released. Along with Goti and the entire GlobalCast team, thank you for doing all the hard work. I did nothing, I think. All right, we're going to jump into it in a minute, but just to give you a little bit of housekeeping and history. So in 2012, old house with Whit Holcomb, and we talked about this need because, as Mac always says, I do everything selfishly so that I get smarter. I said, we need a review course because I feel like I can't keep up with the stuff I actually need to know. There's a lot of publications. So I said to Whit, let's do a review course. And Whit said, let's call it an update course. So that's where the name came from. But we made rules that we have stuck to now for 11 years. Rule number 1, it had to be free to the world. That's what we've stuck to now. I said to Whit, how are we going to ever pay for that? He said, we'll figure it out. And over the last 11 years, we've had mostly the same sponsors that have put this together for 11 years. And I'll just say them now. Cincinnati Children's, Akron Children's, Intermountain Health, Lurie Children's, Seattle Children's, O'Shea. Is it O'Shea or O'Shea? O'Shea. Cleveland Clinic, new this year, and Kansas City Mercy. The original founders have been supporting this for 11 years to make this free to the world. So I'm so thankful for you guys to do that. Also, Storts and Medtronic are also helping us this year so that we can put this on for free. That was number 1, free to the world. Number 2, we had to do it in a way that democratized it no matter where you lived. So that's why we've been doing it remote. People don't have to fly here. We make it broadcasted so that no matter where you are, you can watch it, and even after the event, you can watch it after. That was rule number 2. And rule number 3 was designed by my self-diagnosed ADD. I cannot sit and pay attention to long basic science talks. So what this was designed for is no long drawn-out talks about different molecules that I don't understand. This is practice changing what is new that you need to know to change in your practice now. That was the core essence of what this has been. Also, it's not so much lectures as fights, debates, and arguments about how people should be practicing. This is the design of the event, so we ask everyone, online, in person, if you disagree, make your voice heard. That's the purpose of this. We want to get voices together. This year we're doing something to clarify, because Cecilia,
It's the 12th.
The 12th? Yeah. Okay, 12th annual update course. All right. This year we're doing something different because it was confusing people last time. So some of the things you're going to hear today, I would say you should be doing this. This is like, if you're not doing this, you better think about it, change your practice. 2, this is something you may really want to think about doing, but it's not wrong if you stick with the old way. Or 3, this is cutting edge, only early adopters. So we have labeled the talks. Green circle is an easy no risk. This is what you should be doing. Blue square is, it's probably safe to do, but it's okay if you don't. Black diamond, only the brave can do this, okay? So some of you will see we've labeled you as green, blue, or diamond. All right. That's anything else. So I promise everyone every year there will be technical issues. We've never in 12 years had an event that has been purely without technical difficulties. One year, the entire power grid went out in the city, and we all got in 10 cars and drove to my house, and we did it in my living room. So we will always pivot. We'll always make it work. And if the worst case scenario, we will have everything recorded, and you can watch it after. What else do I need to say? If things start freezing up on your computer, we usually say restart your browser, but lately we have not had a problem with that. Anything else? I think that's pretty much it.
Please, for the audience, write your questions in the chat. If we don't get to answer it live, all the doctors have here the chat, so they will try to answer it there. So feel free to ask as many questions as you want.
Yes, and we're going to try to do better this year on getting all the virtual questions. I did bad last year. I also want to thank the people that actually did the work here. So Cecilia, M, Kiki, Isla, who else did I forget here? Carolyn, we have, and Julie, Claudia, they put all this event together. And James and your team, Red Bicycle, thank you. All right, let's kick it off. We're going to get started. The first event is going to be a recording that we always start with of highlights from last year to update you on the big things that were presented last year. This was put together by M. Guti and Carolyn Roberts. So let's play the video.
shoot a gram, figure it out. Because quite often, it's clean, right? And then you've avoided a lot of needle pokes and a lot of imaging that is not without, I wouldn't say without risk, but just can be a real eye poke. So you avoid a lot of that, and we reduce length of stay and the number of procedures that young kids are getting under general anesthesia. So those are the things we're going to talk about. I'll turn it over to Dr. Vitale for ERCP.
Right, and we'll talk a little bit about ERCP and its role in choledocholithiasis, cholelithiasis. I think Luke and I had a great time. I really appreciate the invitation to be here. And we had a great time doing this at Cincinnati Children's for our grand rounds, and so we'll look forward to having an interesting talk and debate and discussion. And Dr. Ponsky here offers a very unique perspective of being a surgeon that also does ERCP.
It's good that he's between us,
he's
because
right
he is
between
the
us,
hybrid,
exactly.
right?
Wait a minute, and full disclosure, this guy's father, Gary Vitale, is one of the finest surgical endoscopists in the world, who is a pioneer in surgical ERCP. Somehow he got into gastroenterology instead of surgery, but ERCP is in his blood through his daddy. And your dad and I go way back with this, so we'll talk more about who should do ERCP when we get to it, but it's an important thing, and surgeons can do it. Go ahead.
Excellent. Let's go to the next slide. All right, first clinical scenario. 15-year-old female, 24-hour history of colicky right upper quadrant pain. Total bilirubin is 2.3. A little bit of an elevated lipase, not bad. Ultrasound is dilated. Oh, it shows a dilated common bile duct at 1.9 centimeters. There is a stone that is visualized. Next slide. That's the scenario. Is there a slide up here? Okay. What's our next step? What are we thinking? We're going to give time for people that are remote to answer. And we've got several options listed here. Let's just walk through them.
Yeah, so, IV antibiotics, obviously, we don't have any evidence that this patient has...
Don't give the answer.
We're just talking. Okay. We're giving people time.
Answer.
We're just going to...
What do people do in this room right now? IV antibiotics, MRCP, surgery first, call GI.
Surgery.
We're hearing everyone saying surgery. Is there any... Whit is disagreeing? What?
Well, I don't disagree, but I think it depends in the setting in which you reside, in the hospital setting that you reside, and your own technical capabilities. Now, we've had this discussion for 30 years, and I always come back to this one point that if you don't feel comfortable doing it, then you should you do X?
Right.
If you have a GI colleague who you work closely with, should you do Y? That type of thing. So I think that's important because not everyone in the world has the same capabilities as everyone else.
I love that point. You'll notice there's a bunch of asterisks on those two options, right? And that's specifically because, as I mentioned, all quality is local. It depends on, if you've got a unicorn, what are people saying here?
We got incredible agreement
wow.
Around the whole world. Everyone agrees.
MRCP, surgery first. Interesting.
Call GI, yeah.
That's why this is a good topic.
Exactly, yeah. So I think one thing we want to touch base on, too, is that we have definitely seen anecdotally and via literature, stone disease is really increasing along with obesity in pediatric patients around the world. It's not just a United States issue. And so we're seeing this with much more frequency now where we have children come in, even young children with biliary stone disease. Yeah. So I think this is an important topic for us to cover.
I think it's, I'll just make the other comment too, and we've just recently published some work showing that a surgery first pathway, or at least that mindset and embracing that concept, really does reduce resource utilization, including MRCP. And I don't know about your institutions, but that MRI scanner is running 24/7 because there's a lot of people who need scans. Some of them are lengthy. It's a precious resource. Let's go to the actual answer. I don't remember what I put. I did this slide in particular. Yeah, surgery first. Okay. So part of this is, we can quibble about this, but I did want to highlight Dr. Ignacio and the Webster folks. There's a couple of Webster members here in the audience that have contributed to this big Western pediatric database, and they define this very specific and predictive score for choledochilothiasis. It's, I think, a T-billy greater than 1/8, common duct stone visualized on ultrasound, and a dilated CBD. And it's actually, they ran it through, they had a holdout set, and they validated the model, and it's actually one of the most predictive models for choledochilothiasis in this patient population that has ever come out. And so this is from the Journal of American College of Surgeons in 2023, and it's a great way to start a pathway. To have a pre-op pathway, you should incorporate, I say, maybe a green recommendation for thinking about incorporating the duct score in your preoperative pathway for these children that are coming in through the ED.
I'm in full agreement with that. And I think a lot of times before, as a gastroenterologist that does ERCP for children, before I even get a call, before anybody reaches out to me, the patient has had an ultrasound, they've had an MRCP, they've had all this workup, and we can utilize some of our predictive factors where we can go straight to doing a procedure if we need to, whether that be, a combined procedure with a laparoscopic cholecystectomy and IOC, and potentially call me into the room if an ERCP is needed, which our team at Cincinnati Children's does quite a bit. I think definitely utilizing predictive scores like this is worthwhile on our patients.
And let me this may be a black diamond recommendation, but let me just paint a vision for this.
Here it comes.
This score utilized in the ED, surgery's called, we have the bandwidth and the OR availability, we go to the operating room, we intervene, sometimes it's just some sludge or a small stone, we flush it through, we have a clean gram, we're sending them home from the PACU.
And then we always have to help Luke here. Cholangiogram.
Cholangiogram, yes.
The world.
Yes.
In the
Intraoperative
podcast,
cholangiogram.
we had to go back and change all of those to. Yeah.
I remember that. Yeah. Sorry.
So the pendulum swings on this, or is it more what? JP, you were going to say something.
This is flat, but you have to add some depth and perspective to all of this. ERCP is a great procedure. I love to do it. It adds morbidity to a procedure, potential morbidity. And so we know that as good as you are at ERCP, you're going to get pancreatitis 10% of the time. And if that kid gets pancreatitis and you could have gone straight to surgery, that was a mistake. So it depends what the surgeon can do. If the surgeon can't do a cholangiogram, well, that ends the game. Then you need to do an ERCP if someone can do it. If the surgeon can do a cholangiogram and even a choledochotomy, if there's a big stone in there, then you go right to surgery. It's clear. So again, what Whit said, depends on what you have in your institution.
So, and then this will probably just give you a softball for the rest of your thing, but I always call myself out on this. I don't feel I'm great at stone removal intraoperatively because I've been so spoiled with ERCP. I don't know the tricks. I always call people like, what do we do here? Do we put a Fogarty? Do you get a basket? I've done very few in my career. So pediatric surgeons or general surgeons have to step up our game and have to have courses somehow to learn all the tricks on how to get these stones out, so I feel super confident.
Sure. And I think if you know how to put in a central line and you understand the principles of Seldinger technique, then you can do this. And I mean, that's the reality is like, how do we democratize this? Because a lot of the stone disease, and I don't know if this is going to be in here, but we recently published in JPS and showed that we were able to achieve with a surgery-first mindset, and it was surgery-first versus endoscopy, and this is multi-center, so this is not just in my shop, but with surgery-first, the stone clearance rate or the negative intraoperative cholangiogram, meaning no stones, was 86%. And if you just did flushing, if you just got that catheter a little bit more, just peek it in the common bile duct or maybe ream the sphincter, that success rate was in the 90s. So it doesn't take much, and that's the dirty little secret is like, let's do something that I think is accessible to everybody. We're not talking about getting out choledocoscopes or playing the claw game and burning these children with hours of fluoro as we try to fish these stones out. We're talking about doing stuff that's simple.
Greg, go ahead.
Real quick questions. Does your algorithm change if the patient presents with signs of cholangitis?
Oh, we're getting ahead of us.
Yep, you're a couple questions ahead.
That's good. Yeah, we should keep going. We should keep going.
I was going to just push back on the choledochotomy concept. I think clearing ducts, great. Also, you have to factor in age. A teenager, sure, you can do more aggressive things, but Having had to fix bile ducts on smaller kids, it's not near as straightforward.
This bile duct is 2 centimeters in diameter. It's as big as your wrist.
But my point to that, but my point of that is, as you think about the spectrum of diseases that pediatric surgeons face, it's a little bit different profile than that of adults. And if this is a 5-year-old, your algorithm might be a little bit.
Let me be very clear. It's transcystic. We're talking about through the cystic duct. If you can't get in there, then I say you bail and you call a friend. Like I mentioned, choledochotomy should be mentioned in this situation, in my opinion, only to be condemned. You don't need to be opening up the common bile duct and fishing stones out when you've got buddies.
Wait a minute. I just have to disagree with you guys. There's some old surgeons here. The bile duct should belong to the surgeon. The bile duct should belong to the surgeon. This bile duct is almost 2 centimeters. That's a big bile duct. If you get in there and find a huge stone in there, 2 centimeter stone, doing a choledochotomy over that, making a small incision and popping it out is so easy that it is really worth doing. So I'm not saying you should do it in a 1 centimeter duct, but a 2 centimeter duct with a huge stone or multiple packed stones is easy to do. We should all know how to do that. So strive for that.
David, those are fighting words.
I think that's a black diamond situation there. So, I mean, multiple stones, big stones, the risk, especially in a large duct like this with stone, the risk of pancreatitis with an ERCP goes down, as you know. And so the cannulation rate is very high. Even in pediatric literature, when we're looking at stone cases alone, the risk of pancreatitis is less than 5% in the literature. So I think, if you're talking about choledochotomy, at least to me, call a friend, especially.
I'm going to fist bump you on that one. And only because we got to democratize this. We got to, if you're trying to get traction with an idea or a concept and push it forward, you have to make it accessible to people. And if I was up here saying, I agree with you, we all have the prerequisite skills, certainly in this room, from an MIS standpoint, to open up that duct, fish stuff out with a Fogarty or what have you, and then sew that duct up. I don't think everybody's going to have the appetite for that. So we gotta get our wins where we can.
So 85% is terrific, but I think what may be intimidating to surgeons is the 15% that are unsuccessful, and what is your plan for that? Because that, I think...
You clip, you get out of there, and you call your endoscopist.
And do you do that in the OR? Do you...
If you have the availability. I mean, at Cincy they do, right? At Cincy they do. He'll come
I think
in
it
there.
depends on where you are and what you have, At our institution, if Greg or Nelson are in the OR, they'll call me. They call me from the OR and they say, hey, come look at this IOC. We haven't been able to clear the duct. And most of the time, we're able to run over there and do an ERCP pretty quickly. Stone cases, most of the time, are pretty quick. So I think, that's what we do. If you're in an institution where you don't have ready access to an ERCP doctor that's going to come running to the OR, you put a clip on it, you close up, maybe an endo loop, because the ERCP is going to happen soon.
I'm an endo loop guy.
And they go in, within the next day or two.
We have to. I got the signal that we have to move on. This is just an example pathway. Came out of Vanderbilt. They did great work there. We're going to try to push this out to people. So more to come on that. Next slide, please. Okay, we change it around a little bit. It's the Friday before Labor Day in the exact same scenario. And this only, and I made this slide, I did not consult with David, but this is only to stress the point that there are times when potentially, especially in centers that don't have pediatric endoscopists that are skilled in ERCP, and you're beholden to your adult colleagues that may be in a completely different building across town or across the street, it can be more difficult. And so, I just turn the temperature up a little bit on this scenario, and would be curious to know if people have different thoughts based on that. But we can move through this question pretty quickly. This is a poll.
All right,
question.
so the poll's live, right? Has someone activated the poll? Poll's live. As soon as you guys think enough have responded, show it there. We have about 10 seconds for comments before we show the poll while we're waiting for people to catch up. What do you guys say?
You've convinced some people here.
Oh, we're changing the, yeah.
Hey,
yeah.
So I was going to say the first couple times you do this with the wire and dilator and a balloon and all that, you're going to hate it. After you've done a few, the learning curve, it's really actually kind of fun to do. And I'd say the biggest key to success is have all the stuff that you need to do this in one spot because nobody in the OR is going to know what to get. Go shopping in IR. They'll probably be on vacation and not care. And
you have to know how to break into the IR storehouse of toys.
You need like a really floppy tip and then get the right balloons. The 20 millimeter seems to be the best one. So
yeah, and I don't know if we're going to get to this because of the time, but I think it really depends on what you see on your IOC as well. If you've got a common bile duct that's chock full of 3 or 4 stones impacted there, you're not going to be able to be typically very successful with this type of technique, with surgery first. If you see, signs of, some other things, you may want to call your GI colleagues. If you see one small stone and you flush and it doesn't come out, using some of these techniques.
We have a question about that. Yeah, exactly.
Yeah,
exactly. So this, only just to mention this briefly on the answer slide here. This is the Choledochal Lithiasis Alliance for Research, Education, and Surgery. It's a multi-center group. It's a ton of fun. Dr. Jess Rao has been the main herder of all the kittens to get a lot of these papers out, but one of them specifically is talking about after hours and weekend. And can we reduce length of stay with this surgery first mindset? And the answer is yes, and by a lot. Next slide.
Yeah, and I do want to point out that's a great study, great collaboration. All centers that do not have somebody that does pediatric ERCP.
Exactly.
So that length of stay, I think, is probably influenced a little bit by waiting for an adult provider or transferring a patient and that kind of thing.
You're right, but that represents the majority of the centers in the country. All right, clinical scenario number 2. We have an 8-year-old with sickle cell disease, elevated bilirubin. Baseline's around 6, but this is, 10 or 12. Lipase is normal. MRCP reveals stones in the common bile duct. What are our possible answers? Next slide. Okay, so again, we're a little bit of a nuance. We got a smaller child, something that seems to be almost elective in nature. It's up a little bit, but he's otherwise clinically fine. Does that change how we think about this? Thoughts from your perspective?
Yeah, so I think in our institution, this patient would certainly go to ERCP. Now, most of the time, what we're trying to do, and I think we have an old slide deck here, so we didn't get a couple of slides in, but that's okay. One of the things that we've published on as a group of pediatric gastroenterologists that do ERCP is that we can do same anesthesia ERCP with a cholecystectomy. So more than likely, we would be attempting to have a combined OR time where we're doing an ERCP, especially in an 8-year-old like this with potentially a slightly smaller duct. We're going to do an ERCP, and then the laparoscopic cholecystectomy will happen at the same time. Now, most of the time, rendezvous if needed, right? Yeah.
Exactly.
So most of the time, the lap chole is going to go first. There's going to be an intraoperative cholangiogram. They're going to potentially try to flush, and I would caution when you're flushing, one of the things that can happen is if the stone is impacted, you can highlight the pancreatic duct. And I think as soon as you start seeing that pancreatic duct light up, that is definitely a signal to slow down on your flush. Be careful because you can cause pancreatitis in these patients just by flushing contrast into that pancreatic duct with a stone. And so when you're attempting that method, make sure you're careful and watch out for that.
Gotcha. It looks like we're about split on elective chole versus ERCP first. I think this answer, elective chole, is a little bit misleading because obviously you're going to want to deal with the stones in the common bile duct. But nevertheless, good discussion. I think, having relationships, coordinating things, having all the tools at your disposal is really important. And you had a couple of questions that may not have gotten into this deck, so we'll talk to those. Next slide. This is just the same CARES group, and again, pre-vetting by Dr. Vitale, I just threw some stuff out there, but this is another study that shows, and I've already referenced some of this data, the 86% success rate. And I'll just put this out there, but the complications, so the ERCP group, it was a 10% complication rate, and that was cholangitis or bleeding and pancreatitis, so hemophilia and things like that. Nevertheless, it's a known thing. Let's go on to the next question. This is just a toolkit. This lives on the APSA, the American Pediatric Surgical Association's website, and it's just a bunch of tips and tricks and videos and part ordering numbers and things like that, so you can build your own kits. Next slide.
There's one.
This is the one I like. This is the one I wanted to talk about, and I really got a sense for this, and I included it after a recent IPEG meeting where some of the South American surgeons are talking about the rate of spontaneous stone passage. So this is a 16-year-old male. This is actually a patient of mine from about 4 months ago with right upper quadrant pain. He is currently being treated for ALL. He's neutropenic. LFTs are through the roof. The ultrasound is concerning for acute cholecystitis and choledochal lithiasis. Okay, so now we have a little bit more of a different situation with the neutropenic, thrombocytopenic patient. What are we going to do?
So while we're waiting, you'll put the poll questions up, right?
Yeah, let's throw the questions up.
So the questions up. So while we're waiting, we have a question from the audience.
Yes.
So, Ben?
So there's a question about what if it's an infant with stone disease in the common bile duct?
Yeah, so I think from that standpoint, we're really, an ERCP is probably the best step. And it depends on what the stone disease is from, right? Because we're going to have a little bit more information about this. Does the patient look like they might have a choledochal cyst?
You could do ERCP in an infant?
Sure thing.
Hell yeah,
so
man.
Anyone more than, we've done them in 3 kilo babies, right? So we have scopes. And they're available in the United States for rental by anybody.
Dad, he just
smoked
you.
He's a unicorn. He's a unicorn, people.
We can do this.
You just smoked my dad because I thought he was Superman because he could do 3-year-olds. Yeah. Infant, man.
He's got better skills than we do.
So it's feasible, and I think a lot of times in those patients, there's 1 of 2 scenarios, right? It might be a patient who's had some surgical procedures, not been eating, is on TPN, and they've got some stasis and some sludge in the duct that we can clear easily with an ERCP. The second scenario oftentimes is the patient may have some type of choledochal cyst. And they've got an obstruction in stones, maybe an anomalous junction. And so we really want to define that well before you just go in and take a gallbladder out, right?
Well, I'm going to push back on that a little bit because in this scenario for an infant, if you have the capability, you're probably going to have an MRCP to further delineate that and look at the ductal anatomy. So hopefully you have at least an indication of whether or not you're dealing with a congenital problem. If it's insipated bile, you can certainly, we're talking 5 French micropuncture through the gallbladder, a little wire, and you can flush that whole thing out. We've done that. We have a series of about 3 or 4 patients where we've done that, and I think that's going to get published soon. And we leave the gallbladder, a little PDS endo loop on the gallbladder, and we're not, we just kind of sneak in, do the thing, and get out. And so it is another option.
So there's just one other thing about a patient like this that's debilitated, a high risk for any incision anywhere. The ERCP, you can add to that.
Going back to the question. So we're off the audience. We're going back to the scenario now.
Okay.
Yeah.
Yep.
You can drain that duct without doing any incision in it. So if that patient's a high risk for bleeding or any surgical procedure, if you have to, you can do the ERCP and put in a small stent to just decompress the duct and get rid of the sepsis while you get that patient in better shape for surgery.
Yeah, absolutely true. And I think the most important thing in these type of cases is their cholangitis. Ascending cholangitis is an ERCP. I think without a doubt. We just had a patient come into our institution last week, norepinephrine in the PICU. We were doing an ERCP 5 hours after they showed up, putting stents in. So I think it really depends on the presentation of the patient. If there's cholecystitis, we need to know, is there concurrent cholangitis, which a lot of times there is, especially if there's biliary
in this
obstruction.
young man, there was not. He was on the floor and doing okay. But I will also, take a green color recommendation for cholangitis is not the time, just because you have a hammer, that's not a nail, that's a screwdriver. You need to get a screwdriver. So, ERCP would be the way to do it. We see I think there was some responses there. Let's get back to the audience poll thing. Yeah, I think over half the people said, hey, let's let them chill with some antibiotics and let's trim these LFTs. And that's what we did. We did that, and he spontaneously passed the stone. LFTs came back down. We were able to get him his counts recovered and get him to elective cholecystectomy.
And I want to bring up one other scenario too for the audience, which is gallstone pancreatitis, which I think is a little bit different, than our conventional show up with a stone in the duct. And want to hear from maybe some people in the audience, what is your management there? Because I think, in my experience, a lot of surgeons, some surgeon will go in and say, hey, we're going to do this, cholecystectomy within a few days. Some will say, hey, we're going to wait for a week. From an ERCP standpoint, unless there's a persistent biliary obstruction or cholangitis, we're not jumping in to go do this case right away. So just want to kind of hear from folks about gallstone pancreatitis.
Nobody? Bhargava? Nelson?
Yeah.
Okay.
Gallstone pancreatitis, definitely ERCP for us, depending on how long the inflammation has been there. I wouldn't wait for a week to get the gallbladder out. If there are stones and the enzymes are coming down, symptoms are better, then I would take the gallbladder out.
Yeah, when things are improving, we don't need to see biochemical normalization, but when the symptoms are improving, we go right to cholecystectomy with intraoperative cholangiogram and coordinate with you just in case there might be a need for an ERCP.
There's been some studies done to show if you wait 1 day when the patient comes in with acute biliary pancreatitis, if the amylase lipase go up, then you do the ERCP because you have it impacted. But most of the time it'll go right down. Yeah. And if it starts going down, they pass the stone and you can go to cholecystectomy.
We've got just a few minutes. Let's jump to the next question here. Good discussion. Okay. This is just from my standpoint. Most stones can be cleared. Obviously, we've talked about a lot of the ERCP. Some stones pass spontaneously, right? We have to use good judgment with that. And local resources, this goes back to Dr. Holcomb's comment at the very beginning. You have to factor in what you have available to you. And for certain audience members in other parts of the world that may not have ready access to fluoroscopy, for example, or that's difficult, obviously some of these techniques are more difficult to employ. So all qualities local. Next slide. Okay, unsuccessful common duct exploration. You decide to flush and you get some glucagon. You do see contrast. For those that have adopted this or started to dabble in this, you do see contrast in the duodenum on the intraoperative cholangiogram. Let's see, that's our scenario. Let's see, what do you do next? Let's get our answers up there.
Hey, Lucas, could you explain how to mix the flush with the glucagon? What doses do you use?
So the glucagon we just give one. Yeah. So the question is, what do we do for our flushing for the intraoperative cholangiogram? What do we do with our glucagon? We're actually giving the glucagon systemically. Some people are using a little bit of lidocaine in the actual thing that's injected into the biliary tree, thinking that may help relax things. I typically use a 50-50 mix of contrast and saline for all of my flushing maneuvers.
2 minutes.
So I hope that answers your question, but yeah, we give it systemically. We have the anesthesiologist do it. So what do you do in this situation? You got something you can't clear. You see contrast flowing in the duodenum. It looks like a, 7mm stone. What do you do?
Bhargava. I usually do a balloon sphincteroplasty and then try to flush it out still.
Okay.
You can do that with the Fogarty, or you can actually get the balloon.
So you like C, grab a balloon, grab a spyglass, okay.
Yeah,
who's calling GI?
It'll depend on what you have available to you, and also one point I want to make. That's a great point, Bhargava. You can dilate the sphincter. One thing you want to be really careful about is do not dilate larger than the size of the bile duct. So if you got a 5mm bile duct in a stone that's not so obstructive, you got to be careful. If you dilate that duct to about 10mm, you're going to cause pancreatitis.
There's something that Dr. Ponsky taught me too about that actual dilation maneuver that you have to be really careful at. And I've ever since you said this, we've been employing this, but it's the idea that come up, get a little bit of a waist in the balloon, and just hold. Let that thing stretch slowly, and then you come up to profile in a very controlled fashion and leave it there for a while. We've been leaving it for 5 minutes to avoid that rebound spasm of the sphincter. Okay, somebody wanted to see the IOC, and I think that's great, and I'm going to turn it over. Not all IOCs are equal. We're trying to define that, because sometimes you just see things taper down to a little nothing, and that's just sludge. Sometimes you see a very well-defined meniscus. Sometimes you have these massive boulders, and multiple of them, even in children.
Yeah.
And so I think that is a really important thing is like, what do you have available to you? You've done a flush maneuver. You may want to take the next step. You may want to grab a balloon, as somebody in the back said. And I think understanding what you're dealing with in terms of the burden of disease is really important.
Yeah,
I think if I have a bunch of boulders, I'm gonna bail and call.
Multiple stones, multiple large stones, you're gonna want to call your GI colleague. The other thing, when you're flushing, you make sure you watch that stone, because if you flush that stone and it starts floating up into the bile duct, and you make a very, very simple case with a stone sitting in the common bile duct, you can turn that into something very, very difficult if it flies up into the intrahepatics, which is a much more difficult ERCP. It can get impacted there. So pay close attention.
The bottom line is, I think, doing more intraoperative cholangiogram, getting comfortable with it, interpreting it, getting the flow down, building the relationships with the people that either need to be coming into the operating room or that will be seeing these patients after, or maybe even before. Developing relationships and taking just a first little step and then the next step to really try to reduce length of stay and hopefully the number of procedures these kids have to go under. Is there another slide on the?
And a lot of this is going to depend on local expertise, what you have available to you, who you work with in your hospital. All these things are very, very important.
All right.
Yeah.
We good, or do you want to final comment? All right. This was like a massively high yield session of about 30 different points. Again, we'll have all of this recorded, chopped up, and we'll submit all of these out so everyone can see it. As always, I practice like a historic dinosaur, so I'm learning the new ways now, so I love it. Thank you for putting this session together. The three of you, this was phenomenal. Thank you so much.
Thanks so much, everybody.
Thank you.
Thank you. What a pleasure. Yeah, and I will be pushing to make sure we stay on time, because I know this is a long day and we don't want to keep people here. They have to catch flights. All right. We're now going to try that video again, see if it works this time. This was a recap of the last year highlights of this is, okay. This is best of the best. That's a little different. So best of the best is something that we do. This is the summer course, well, summer in the United States. And then we have a winter course in December or January or something like that called Best of the Best. This is submitted by practicing surgeons who have updates. Best of the Best is a collection of all of the best papers from all of the meetings around the world, because nobody can go to every meeting. So we ask all of the societies to send us their top article, their top presentation, and we present them once a year where you can come and watch the All-Star game of each of the best presentations internationally. We even vote and have brackets and see who wins. I don't remember who won last year. But why don't we go ahead and roll Best of the Best. We'll see if this plays.
MD, along with Cincinnati Children's Hospital, sharing knowledge to improve child health around the globe.
Hi everyone. In February 2024, we held our third Best of the Best in Pediatric Surgery live event, and we are bringing you the top 4 key takeaways from that day. We're starting with number 4. Our first key takeaway is about post-op opiate prescription and racial disparity. Here, Dr. David Grabsky, a pediatric surgery fellow, presented their study to us.
We implemented a multimodal intervention to reduce postoperative opiate use in children at our institution based on IV Tylenol, directed postoperative pain education seminars for related faculty and staff, and standardized post-surgical sign-out.
The purpose of the investigation was to determine if a difference in opiate prescribing patterns existed by race in their historical cohort,
and whether our intervention, and more specifically the standardization of care, had an effect on any potential racial disparity that was identified.
The investigation included children under 1 year old who underwent non-emergent abdominal surgery in either the NICU or the acute care floor across the study period.
We used a historical and retrospective pre-intervention cohort group to compare the effect of our intervention on postoperative opiate prescribing patterns, pain scores, and secondary outcomes, including clinical safety profiles.
The primary analysis was process control charts. Post-op morphine equivalents are represented on the y-axis, and the time is represented on the x-axis, beginning in the January 2011 through January 2021.
Our intervention occurred in January 2016 and is denoted by the blue vertical line. This figure reestablishes that the intervention itself was successful in reducing postoperative opiate use by 98% in our study population.
This is the exact same data, but now plotted by race.
White children are denoted in blue, Black children in orange, and Hispanic children are represented in gray. Concentrating on the pre-intervention cohort to the left of the blue vertical line, it is clear that Black children were prescribed significantly higher postoperative opiates than their peers.
For numerical comparison, the median post-op morphine equivalent for Black children was 13 milligrams per kilogram, while for white children it was 2, and Hispanic children it was 3.5.
This represents a 6-fold increase in postoperative opiate use in Black children compared to their white peers.
Let's look at the post-intervention cohort. It is clear that the intervention successfully reduced post-op opiate use in all racial groups.
Specifically, the median postoperative morphine equivalents in Black children reduced to just above 0 milligrams per kilogram, while for white children it was 0.05 and Hispanic children it was 0.1.
These findings in the post-intervention cohort were statistically equivalent. In summary, the data is consistent with a racial disparity specifically highlighted in Black children in the pre-intervention cohort, which was eliminated following the implementation of a clinical protocol and standardization of care. In number 3, we'll review the new findings assessing a possible link between congenital surgical anomalies and mental health disorders, including anxiety, mood disorders such as depression, and substance use disorders, with Matt Yurchak. He's a third-year medical student at the University of Manitoba.
Congenital surgical anomalies are major anomalies requiring neonatal surgical correction for survival. They require prolonged hospital stays, exposure to general anesthetic, and increased exposure to the healthcare system throughout childhood.
While there is substantial research completed on early clinical courses of these children, there is substantially less on their long-term mental health outcomes.
We collected data on every child born with a congenital surgical anomaly in Manitoba, Canada, between 1991 and 2022.
They analyzed 818 children born with congenital surgical anomalies, and they had nearly 8,200 controls.
Here, we're looking at a table that will show the hazard ratios controlling for the child's sex and their socioeconomic status.
Values above 1 indicate higher likelihood of diagnosis in children with a congenital surgical anomaly compared to the control group.
Statistical significance is denoted by an asterisk and will be highlighted in yellow.
In the diagnosis of all mental health disorders, there's a descriptive but non-significant increase in individuals with congenital surgical anomalies.
In anomaly-specific analyses, only anorectal malformation saw an increase in risk, being about twice as likely to be diagnosed with a mental health disorder.
For anxiety and mood disorders, there is no significant increase in children with congenital surgical anomalies.
Only patients with anorectal malformation were found to be at an increased risk, being about twice as likely to be diagnosed with anxiety disorders, but not significantly more likely to be diagnosed with mood disorders.
And next, we have substance use disorders. Pooled analyses indicated a significant 86% increase in diagnosis of substance use disorders across all anomalies.
This was largely driven by patients with anorectal malformation and esophageal atresia, who are 4 times as likely to be diagnosed with this disorder.
In conclusion, children with congenital surgical anomalies are likely not at an increased risk of mental health disorders, including anxiety or mood disorders.
However, these individuals are at an increased risk of substance use disorders as they grow up, and parents should be aware of possible signs of substance misuse in their children to ensure that early intervention and care can be given to those who need it.
And we believe that adequate support and screening should be implemented to ensure these individuals receive the necessary care to optimize their long-term health and well-being. For number 2, we have a study from the Multi-Institutional Pediatric Colorectal and Pelvic Learning Consortium. Dr. Srinivas will share their findings on how outcomes from colonic pull-through for cloacal exstrophy vary based on colon length. Cloacal exstrophy is a rare congenital abnormality involving a grouping of anatomical variations. It affects approximately 1 in 200,000 pregnancies and occurs along a spectrum of severity.
Over time, the management of cloacal exstrophy has evolved and survival has improved. However, the initial surgical management remains the same and is focused on drainage, with an edge colostomy or ileostomy and drainage of the bladder.
As children grow, the opportunity for reconstruction emerges.
From a colorectal standpoint, the main question has been whether or not a patient should have an endostoma or if they're a candidate for a pull-through procedure.
Early studies resulted in a great deal of popularity of the colonic pull-through. However, it's unclear whether pull-through remains heavily utilized today.
We utilized a multi-institutional collaborative across the United States, from 11 major pediatric hospitals over a 10-year time period.
They performed a retrospective cohort study of 98 patients with a diagnosis of cloacal exstrophy.
We collected data on their demographics, operative course, and cleanliness, which was defined per standard terminology as 1 or fewer accidents per week.
All patients underwent an initial stoma creation at a median age of 2 days.
For those that underwent pull-through, the median age at pull-through was 1.3 years.
Of the 98 patients in the cohort, only about 29% received a pull-through. There were 5 patients that were required to redo stoma for various reasons.
This leaves 24% of the initial cohort who continue to use their pull-through. Of these, the majority of patients are not clean.
In this cohort, only 1 patient is continent or not having accidents without the use of bowel management.
This represents an overall successful pull-through rate of 7%. Roughly 21% of the population has an unsuccessful pull-through.
Meaning they're not clean or they went back to an ostomy.
We then compared these 2 subgroups to one another.
The group with successful pull-through had over double the preoperative colon length compared to the unsuccessful pull-through group.
This demonstrates the first association between a longer colon length and a greater chance of success following pull-through.
In summary, in a multi-institutional sample, research has demonstrated that most children with cloacal exstrophy will keep their stoma indefinitely.
Of the children that undergo a pull-through, only a small percentage are able to be clean for stool postoperatively. A longer colon length correlates with higher success post-pull-through.
Overall, this suggests that colonic pull-through can remain effective for children with cloacal exstrophy. But then it may be selectively offered to children with an adequate colon length. We're ready for the most anticipated video of the day. Number 1 key takeaway, and the champion of the best 2024. In this video, we'll learn from Dr. Derek Petkowski, a legendary pediatric surgeon from Poland, about internal traction technique to bridge the gap between the esophageal pouches of long gap esophageal atresia using staged thoracoscopic approach.
All 27 cases of long gap were operated. Both ends of the esophagus are brought together under tension with internal traction suture.
This is static, not active tension.
The preoperative rigid bronchoscopy is a standard procedure to check for upper fistula and any tracheal malformation.
The patient lies in a prone position on the edge of the operating table. The right scapula is the anatomical reference point for trocar placement.
The distal esophagus is usually located at the level of the diaphragm. It is dissected bluntly from surrounding tissues. The upper esophageal pouch and, if present, the fistula are dissected in a similar manner.
Dr. Petkowski mentions that there is no need to use electrosurgery here.
The fistula is ligated on both sides and cut. Instead of a ligature, you can use clips or a 5mm stapler.
Placing the internal traction suture requires full thickness of tissue, including the mucosa layer.
For internal traction, we use a 2-0 non-absorbable braided suture.
According to Dr. Petkowski, the technique of tying a sliding knot in a small space requires a lot of skill and experience. It is one of the bases for success.
2 sliding knots are made on both arms of the suture. The clips are placed to cover the entire thickness of the tissue and part of the suture.
This method prevents leaks and allows for greater force to be used for traction.
If necessary, both sliding knots can be converted to move in both directions. There is no need to rush. Time is needed for the tissue to stretch. Wait a moment. Be careful when applying traction force so as not to damage the tissues. Finally, the sliding knots must be blocked.
We'll learn a few more tips on the process of this technique. Subsequent stages are performed every 1 to 5 days. There is no need for a gastrostomy. The patient remains intubated in the intensive care unit on parenteral nutrition.
We don't use chest drainage. I am personally against suction with Reproc tube, as it dries the mucosa, in my opinion. I prefer intermittent suction on demand.
Anastomosis is possible if both ends overlap, but care must be taken when deciding.
There is no way back. Any failure will result in the loss of part of the esophagus. After pouch's opening, the 8 French nasogastric tube is passed down into the stomach.
Traction must be maintained until the first sutures are placed, because both esophageal pouches can easily retract, making anastomosis very difficult.
The basis of the perfect anastomosis is a sliding knot.
Typically, you need to place 2 or more sliding knots and then gradually close them.
It doesn't matter whether the anastomosis begins from the anterior or posterior wall, as the anastomosis can be rotated freely around.
If anastomosis is not possible, the sliding knot can be reopened and used again to bring pouches together.
We use the thoracoscopic internal traction technique in 25 cases of long gap esophageal atresia and completed with anastomosis in 23 cases.
Most cases were completed in 2 stages. Initially, the time between stages was about 4 weeks, but this was reduced to a few days now. In conclusion, Dr. Petkowski demonstrated that the thoracoscopic approach using internal traction technique has the potential to change the way we manage the long gap esophageal atresia cases. Thank you for watching this video.
All right, phenomenal video, Em and Carolyn. We're going to play another one, but before we do, I just want to point out something. The lab that we have had now for many years focuses on looking at how we can best disseminate information. It's really hard to get important information seen by everybody. And so the lab is constantly pushing the limits on how we can do it. What you saw there just looked like a regular video. Em and Carolyn Roberts and Cecilia and many others have found that by taking something, cutting it down into a fraction of the time and narrating it is more appealing to the general public, and it is much higher viewed. Then we figure out ways to disseminate it. But what's really cool, and I don't know if that video showed it, but we're now using AI. And we can cut down the time to make massive amounts of videos that we believe or that others believe are the most critical ones. And to get it out to the world, we're using AI tools that allow us to do it in literally in a couple hours instead of a couple weeks. So a lot of that, the stock footage and stuff is AI generated, and it adds flavor to the video. So I don't know if the next video has the same kind of things, but the second video is now an update on the update course. That was best of the best. This is what the hot things were for the update course. And by the way, the voting on the last one was public voting. There were brackets. The audience voted. Personally, I thought the opioid thing was one of the most startling studies I've ever seen, and it came down. But I also think Darius is probably a world genius. So I thought those were great. Why don't we roll the update course highlights from last year? Thanks, Em.
And number 5 brings us to the updates and fertility preservation session. Here, Dr. Aaron Rowell will discuss the process of removing ovarian tissue for cryopreservation. Dr. Rowell shared a case involving a 6-year-old female diagnosed with hemophagocytic lymphohistiocytosis, or HLH, requiring chemotherapy and thus ovarian tissue preservation for future fertility. It is very important to note the emphasis placed by every society on fertility preservation counseling, even when surgery isn't planned. So how does the counseling process work?
When we have a patient who's got a new diagnosis of cancer or is going to come up to stem cell transplant, they activate our counseling service through an order set in Epic. It's easily available to anyone, and then that triggers a consult by, we have an advanced practice nurse practitioner. I do some of the counseling. We also have somebody from oncology. So we have multiple different people who could be available to talk to the family about that risk assessment.
Another important factor is deciding what is the best procedure for preserving ovarian tissue.
It's really important to recognize this is a prepubertal child. The size of this child's ovary is about 2 centimeters. It's about the size of a grape. And that really what you ought to do is a laparoscopic oophorectomy. That would be our best recommendation.
So laparoscopic oophorectomy is recommended to reduce the risk of hemorrhage and ensure that any remaining ovarian tissue is preserved for the future fertility. So in conclusion, fertility preservation is very important for children undergoing chemotherapy. Counseling must be included in their multidisciplinary approach, and in females, the best way to do it is with a laparoscopic oophorectomy. Getting closer to the top 3, and we have number 4. To talk about the massive transfusion protocol, we'll tune into Drs. Mira Kotogal and Katie Russell. Massive transfusion protocol, or MTP, is a multidisciplinary process whereby blood and blood products can be rapidly obtained for severely bleeding patients. Effective communication is crucial due to the urgent nature of the situation, and having a protocol simplifies the process, ensuring timely access to essential blood products. But when should we activate MTP? And what kind of blood products should we give?
If you're in the trauma bay and you're giving blood,
you need to activate it. Like,
So
it's go
blood
time.
equals MTP.
Yes.
That's its phrase to remember. So if you give blood, call MTP.
Another important thing we learned is the ratio we should give the blood products, which is 1 to 1 to 1, meaning for every bag of blood, you pass a blood of plasma and 1 of platelets.
When do you give something other than packed red blood cells, and what do you give?
If it's a bad trauma coming in, not stable or not normal at all.
Whole blood.
Yeah, whole blood would be the best, I think.
So we have not been able to get our blood bank to make whole blood for kids because it needs to be
Okay.
We want to aim for 1 to 1 to 1,
Okay.
for sure. And definitely FFP should be what you give after you give blood. Most of the time, an original trauma cooler that comes to the bay in most hospitals does not have platelets. So you have to, the MTP helps you get platelets, or you can call for platelets, but they usually don't come in your trauma cooler.
In summary, the massive transfusion protocol should be activated in the trauma bay after administering 20 milliliters per kilogram of blood. Following activation, the protocol dictates providing the patient with blood products in a ratio of 1 to 1 to 1. We're finally in the top 3. For number 3, we will review the management of ovarian torsion with Dr. Leslie Breach, a pediatric gynecologist. Dr. Breach started this session by presenting a case of a prepubertal girl with a right ovarian torsion.
Comes to the emergency department, gets an ultrasound, large cystic mass, no blood flow to the right ovary, and you decide to take this patient to the operating room. You find right ovarian torsion, and you can see this sort of dark purple ovary.
The key thing to watch out for is the presence of a cystic area on the ultrasound. Often, this is less visible in the operating room. And although many surgeons may want to go in and attempt to remove the cyst, Dr. Breach advises against it unless the edema makes it clearly visible.
Now, there's more question about the fallopian tube, how to manage a blue-black fallopian tube. Take a look at the tube. If the tube is black, it's edematous, you have detorsed it, you've given it plenty of time, then I would say a consideration about what to do about that tube.
Therefore, it's best to avoid removing the ovary because it may still regain some of its functionality, even if it appears to be black. Dr. Breach also advises against pexing the ovary. Instead, she recommends just detorsion and subsequent monitoring. In conclusion, ovarian torsion does not always involve a cyst. Therefore, unless it is clearly visible, do not attempt to remove it. To preserve as much ovarian tissue as possible, avoid performing an oophorectomy and ensure the patient is followed up. And for number 2, we'll review total pancreatectomy with islet autotransplantation, or TPIAT, from updates in pancreatitis management session. This time, Dr. Juan Gurria will help us understand the topic. Chronic pancreatitis is a condition that causes pancreatic insufficiency and damage to the islet cells. One treatment option is TPIAT. This procedure involves a complete removal of the pancreas along with the spleen, followed by extraction of islet cells in a specialized lab. These cells are then injected into the portal vein.
In the acute post-op period, you have to manage their glucose for them. If you put them under stress, the cells die. Everybody's on insulin in the ICU. I want the cells to be like just chilling, not doing any work until they implant and find new vessels from the liver to survive.
It is important to understand that many patients with chronic pancreatitis have a gene mutation that triggers recurrent attacks, causing the gland to replace normal cells with fibrosis. This is why performing any surgical resection procedure without extracting the islet cells may result in continued pancreatitis attacks and an increased risk of diabetes after TPIAT due to the reduced pancreatic parenchyma. In conclusion, TPIAT is a surgery for chronic pancreatitis that helps the pain and the recurrent attacks with the idea of preserving as many islet cells as possible to avoid endocrine insufficiency. And we made it to the number 1. I know everyone's been waiting for this. Let's hear from Drs. Mira Kodagal and Katie Russell on management of blunt trauma to the liver and spleen. Blunt trauma is a significant concern in the pediatric population, primarily due to the potential severity and complications associated with such injuries, and its management has been evolving for many years now. Last year, the American Pediatric Surgical Association, or APSA in short, released a guideline including new updates.
So the APSA guidelines are relatively new-ish that came out with revised guidelines around management of patients, and it includes 4 basic categories, thinking about where they should be admitted, procedures, when you would discharge them, and then what you might think about doing after discharge, and particularly in this instance, talking about patients not going to the ICU.
For grades 1 and 2 blunt trauma to the liver and spleen, we can monitor patients who are hemodynamically stable and consider discharging them from the emergency department. Regarding lab results, should we repeat them? And if so, how frequently?
They're gonna get one. I practice out in Utah, and 80% of our kids are transfers. Most likely, they've already had a CBC at the other hospital, but we do not repeat it. If it's a hemodynamically normal child, they will go to the floor and not get a repeat crit.
Perfect. That's what we're doing too. And there's actually data to support that we know there is some degree of hemodilution. The data suggests that the patients who are more likely to fail non-operative management have an initial hemoglobin less than 9.25.
Therefore, for patients who are hemodynamically stable and have normal hemoglobin levels in their initial lab tests, there's no need to repeat the tests unless there are changes in their condition. In conclusion, for blunt liver and spleen trauma, there is increasing evidence that supports treating the patient based on signs and symptoms rather than solely on the injury grade.
Global Cast MD, along with Cincinnati Children's Hospital, sharing knowledge to improve child health around the globe.
Awesome. Phenomenal video, Em. Thank you for putting that together. Always blown away by the AI tools there as well. All right. We're going to move on to our next session, which is on Wilms tumor. Justin Huntington is going to be moderating, and Justin's from Akron Children's. And we have Bhargava Mulapudi from Kansas City Mercy. Is it Mercy Children's Kansas City? I always get it backwards.
Children's Mercy.
Children's Mercy, Kansas City. Children's Mercy, Kansas. And we have Dr. Michael Nightingale beaming in from the Royal Children's Hospital, Melbourne, Australia. So this is something we've been, for those of you who have been with us for 12 years, you know how many years we've been trying to get the audio to work where we can truly bring in all the international speakers as if they're here. We're trying it today. Hopefully it'll work because it changes everything if we can bring in international faculty for the future courses. So Justin, it's all you.
All right. You want to start us off?
All right, let's start with the next slide. Let's start with the first case to warm us up. So we have a 19-month-old male, presents with a newly noted right-sided abdominal swelling, decreased PO intake, ultrasound, CT scan, very suspicious for Wilms. This is what the scans look like, pretty classic. Next scenario is an audience poll.
That's so nice.
Next slide. So we can, while we wait for that, go with some audience questions, and also online if what would differ from PSYOP protocols from what we do with our QOG protocols.
Thank you for doing 3 choices because that increases my odds to 33%. Any comments while we're waiting?
You got imaging of the chest, too.
Question was
negative.
Imaging of the chest?
Negative, no, nothing else in the abdomen.
Any other information anyone needs? Strong opinions? And remember, the polls will keep coming in over the next 20 seconds, but you can, it looked like we could tell there was a split. Oh.
We got a question?
Legitimate question, not to sound smart. Any extension of any tumor into the
No
IVC?
no
or
tumor
the
thrombus. Great questions. No tumor thrombus.
We'll get there.
All right, so I think we can look at those.
Okay. Let's look at the audience poll. Next slide.
So it's back there. It looks like most would do A. Close second, chemotherapy.
It's pretty split, yeah.
Really close. And then third would be biopsy with chemotherapy.
Yeah, this should be pretty straightforward where we should proceed with resection in this particular case. But let's look at the questions and see why any of that would change with different scenarios. So looking at the clinical scenario, so we did successfully resect that. Margins were negative. Mass weighs about 728 grams. Path is also, triphasic, but still has more blastomal predominance. Kind of stage 2 because of the invasion of the renal sinus lymphovascular spaces. Favorable histology. But there's some cytogenetics that we also have. It's negative for loss of heterozygosity, 1p16q. Now, this always sort of confuses me, so I want to, target surgeons. What do we need to know about loss of heterozygosity and what significance of gain of 1q? Any questions? If this were to be something different, if there is a if it's positive for loss of heterozygosity, 1p16q. Does anyone want to know that information? What you would do next? Let's go to the next slide.
Coca, no comments? Figured you'd be jumping off the table with comments, no? Okay.
So based on that,
Margaret, before you go
audience
further,
poll.
I do think, when you look at the audience poll, the reason it was pretty split is because this is an international poll, right? And so
Yes.
our European colleagues would oftentimes offer chemotherapy, no biopsy, and of course that's where the SIOPEL and COG data differ. So I think as you look at that audience poll, it's a reflection of an international audience, so the end result is it's pretty split. I think if it was strictly in North America or COG sites, then it would be very much a resection at diagnosis.
That's a great point.
Really
That's a
great point.
That's a question. Wait, hold on, Dan, repeat that again in the mic.
It also would impact the chemotherapy answer because you would add doxycycline even for a low stage tumor.
Exactly. And this is our next audience poll. Let's see what we do. So we have the weight of 728 grams of the nephrectomy tumor specimen. Age is 19 months. Now what do? Close follow-up per protocol, flank radiation. You do EE4A, which is vincristine and deactinomycin, or DD4A. You add doxorubicin to that. Audience questions?
This is going to be a good poll. What do people here think? Any opinions? Or send to oncology and.
Okay.
All right.
Quiet.
Audience poll. Let's see what we have.
C is coming in first, followed by D, less for A and B.
Yeah, I would go with C too. I think the one reason, as Dan pointed out, you would add doxorubicin to keep in mind if you have loss of heterozygosity at 1p and 16q. That is important for us to remember because that adds some exotoxicity, but that's the one that shows higher recurrence. When you have loss of heterozygosity.
So for this decision, that it's like, which chemotherapy do you use? Usually, it's a multidisciplinary thing. Surgeon oncologist, or is the oncologist the only one who take?
It is definitely multidisciplinary. Tumor board meetings where you kind of present your cases. Surgeon has to be there to give an insight on what happened in the operating room. Make sure your lymph nodes are always out. That's very, very important to get 5 or more of lymph nodes and just give the surgical perspective.
And we have a question from the chat. Is anyone using ICG for lymph node deal?
A little premature question. We'll also get there. But yes, you can. All right, so what's next? Let's kind of change up the scenario a little bit. Next slide. So now, difference audience poll with the different parameters here. Now we have a stage 1 tumor. The weight is 450 grams. Significance of loss of heterozygosity, 1p16q, and also 1q gain. And we'll go into a little bit more details on what that 1q gain is. Let's look at this. Any preliminary thoughts from the audience? Stage 1, 450 grams.
Somehow I think if the topic was appendicitis, we'd be getting so many more comments from the audience. Wilms, everyone's like head down.
Tim.
Observation.
So I just want to say, I think the most important thing here is that there's a lot of stuff that's rapidly changing with the biology here and a lot of open study questions. And so for the surgeons, there's going to be a lot more of waiting for the biology before you determine if chemotherapy is going to be needed. So as we move into the next round of COG studies on this, the group of patients who are going to be eligible for surgery only is going to increase, and so there's going to be, as you're thinking about placing the port, there's going to be a lot more of wait and see what all of these biologic markers look like.
Absolutely, and that's how your patient discussion or family discussion should continue, not just say, if you're less than 2 years of age, if you're less than 550 grams, you will not need chemotherapy, because that's not accurate based on your biology studies. You will have to add chemotherapy if you have loss of heterozygosity at 1p16q. So this is the update from COG, just from the last fall meeting. So this is adverse biologic factors like we discussed, also with worse prognosis in stage 2, but not that much seen in stage 1. Favorable histology, Wilms tumor, but if you have some of the loss of heterozygosity, we're still adding chemotherapy. Next, based on the current enrollment, age and tumor nephrectomy weight was not associated with the event-free survival. This has not made into mainstream yet. So will there be a time where you have older patients than 2 years, higher weight than 550 grams, that with good biology that may not need any more therapy? Very possible. That we have to be on the lookout for. Next is, that's exactly to Tim's point, is to new stratification and modeling treatments for that. Next clinical scenario, this is more on a surgical side of things on what people do. So we have a 10-year-old male with long-standing abdominal pain, presents with what appears to be a right upper pole mass with a IVC thrombus extension, lungs are clear, and there's some enlarged lymph nodes in the abdomen. Audience poll. Still 3 questions, Todd.
I'm kind of interested in the crowd. Anyone do surgery for any IVC thrombus up front? Depends on level. Where are people at? Any comments?
Yes, of course, it depends in the level. If it's until the kind of the atrium, I might go and take it out at the beginning. Anyway, we are following umbrella protocol in Chile, so I don't do that anymore. But I did before when I was following COG. So yes, it depends in the where is the thrombus in the
Up
IVC.
to the hepatic veins or
Yes.
into the atrium?
Into the hepatic veins.
Okay. Okay. Is that pretty much where everybody is? Anybody?
Below the hepatic veins?
Yeah.
Okay.
Okay, when would you biopsy?
Well, again, I guess if you're following COG protocol and you want to give him chemotherapy first, you should do a biopsy. But in umbrella, and it might change at COG at some point, we do chemotherapy up front, unless the patient is kind of older, you know, like 6-year-olds or really small. So they are another histologist other than Wilms.
So we've been sometimes avoiding biopsy if you have family history or if you have some other diagnoses that's very consistent with Wilms. Imaging that's pretty consistent with Wilms. If you don't have a question on what kind of tumor it is or any other issues with you're worried about anaplasia or something different, then would proceed with biopsy. But if not, under 10 years of age, if you're pretty sure it's Wilms, we're avoiding biopsy up front.
So that, I think the COG approach is to avoid biopsy up front, but the other indication for biopsy is if you do give chemotherapy and it doesn't respond as you expect it to, then you would do a biopsy to rule out anaplasia.
Yes.
Because that would change your chemotherapy protocol.
Absolutely.
Yeah, great point.
All right. Let's see the poll results.
All right. Looks like most people are a biopsy chemotherapy followed by resection, number 2 chemotherapy, then resection.
Yeah, so that's what we did here is chemotherapy and resection. I want to get to one more question before we have some surgical specific questions on this. So similar scenario, now it's a 12-year-old female, same presentation, chronic abdominal pain, now also has IVC thrombus, lungs are clear, some lymphadenopathy in the abdomen, initially managed at an outside hospital with an IVC stent placed. Let's go to the next picture. I don't know if the next picture showed up. Anyway, there's a picture with a stent in there too. Go back, please, to the audience poll. All right, so what would you do? How would you manage this particular patient? She also had a IR-guided stent placed. And if we should do that, if there is tumor thrombus in the IVC, and what's the downside of that? And looking at the questions, any preliminary audience questions? Ben?
I was just curious where the stent goes from and to in the IVC.
Yeah, there should have been a picture in there. The stent goes into the atrium.
Are you asking them to advance the slides when you say there should be a picture?
There was a second
I think
picture
it's
in the
missing.
same, go
back.
back to the clinical scenario. There was an overlap picture, maybe it got cut out.
Okay.
Yeah, there's a stent in the IVC. plus going into halfway into the atrium?
So I think that there's going to be some discussion about just collaboration with other services. I think certainly this is one where you phone a friend. You get your interventional radiologist, you get your cardiothoracic surgeons, you get everybody loaded for bear after you've gone through the neoadjuvant chemo, and you go in with scenario 1, 2, and 3, and especially anesthesia. You know, you get into a mess, you know, at the retrohepatic IVC. You're going to need an anesthesiologist who really knows how to keep that CVP as low as possible and then flood them as soon as you get things under control. That's a very dicey situation. So I think it just highlights the need to make sure that everybody is on the same sheet of music and you're not talking about this 15 minutes before the case.
Yeah. Can I ask a follow-up question to that? So how would you approach this for vascular isolation?
I think you may, in fact, need to do a sternotomy and get control at the level of the supradiaphragmatic IVC, right at the right atrium, and just at least have that controlled. Obviously not actually clamped, but the ability to do that. And obviously you'd have a Pringle maneuver. You'd get retrocable IVC control at a place just below the renals. And you know, you would just have everything completely exposed for yourself. I think one of the questions is how much tumor is invaded into that stent. How sticky is that stent going to be? You obviously worry about embolization of the tumor. That could also be something that would be pretty scary. So there's a lot of different things to think through, and I think that's where it just making sure you have solid relationships and understanding the capabilities of your partners and your specialists and what they think is possible.
Yeah. Absolutely, very key to have the collaboration, multidisciplinary. So audience poll answers.
Can we see the poll answers? And then we're going to bring in Dr. Nightingale as well. He's here to make some comments.
Okay, it looks like A and C are pretty equal.
C.
We may have to cut out a couple of your poll questions because we're running kind of late.
Okay.
Let's, Dr. Nightingale, I don't know if you can hear us.
Good morning.
Good morning. We'd love to hear if you have any thoughts or comments on all this so far.
Oh, well, I'm conscious I'm living in the future because it's Wednesday morning here. I think you're still on Tuesday morning. And I'm also conscious there's a group of COG surgeons there where I'm a PSYOP surgeon, and good to see someone from Chile who's also a PSYOP surgeon. Really interesting discussion. Most of those patients would, of course, receive preoperative chemotherapy on PSYOP protocols, and we would have no qualms about biopsying them. The 10-year-old patient there, I think, would definitely get a biopsy in our institution. So some very interesting differences between the two protocols.
Awesome. We're going to keep going.
All right, so I'm going to go.
Yeah, let us know. Yeah. You know, don't be shy. And can he just talk when he, So just, Michael, just talk when you want to, and we'll go right to you. So just interrupt anytime you want, okay?
No problem, Todd. I'll try to be fast because I understand you're running over time a little bit. So can we put up the first slide?
Yeah.
All right. So I'm speaking as a PSYOP surgeon, and I'm just going to talk about your standard unilateral non-syndromic Wilms. And I think certainly in PSYOP, there are three areas that we're looking at innovation: nephron-sparing surgery, minimally invasive surgery, and lymph node dissection. So we go to the first case. I'll just remind everyone in PSYOP protocols, all patients under 6 months of age are treated with surgical intent. They don't get preoperative chemotherapy. So this is one that perhaps bridges between the two groups. Six-week-old female, a solitary mass on the right upper pole of the kidney. So it's a discrete right at the top, separate from vessels, no evidence of rupture or lymph node enlargement. Next slide. So we do a poll. What is your surgical approach to this tumor? Do you biopsy it? Do you do an open radical nephrectomy? Do you do nephron-sparing surgery, or do you do a laparoscopic nephrectomy?
All right, and while we're waiting for that
I'd be interested in it.
Yeah. Go ahead, Michael.
Yeah, thoughts from the audience.
Yeah. Any comments while we're waiting for the poll to generate? Nobody? None of the oncology surgeons? Coca, come on, you go. Dan? All right, go ahead.
She has the two kidneys, no? She has normal kidney on
the other
side. Yes. I guess I'll do a laparoscopic nephrectomy up front because of the age of the patient. to see the histology, I mean.
Any other comments?
Yeah.
Dan?
So I'm assuming that the patient has no underlying genetic predispositions or anything
Correct.
like that. So just to be controversial, I would suggest that there's the possibility you could do a partial nephrectomy, do a nephron sparing, because of that upper pole lesion would be very amenable to a partial nephrectomy.
Yeah, I'm wondering how this patient even was diagnosed, because you don't usually pick up such a small tumor in a small kid, but this seems like a perfect situation for nephron sparing surgery. It's probably a rest also, it might not even be a tumor.
This is ultrasound done for possible pyloric stenosis, an incidental finding.
Let's look at the poll results.
Can we,
Yeah. Oh, there we go.
Looks like nephron sparing surgery was #1 answer. Followed
yeah, and that's what we did with this patient. And I think that is the priority for PSYOP protocols, is to focus on nephron sparing surgery over laparoscopic or minimally invasive surgery. So I think in these patients, we're weighing up the oncological risk of nephron sparing surgery. So it's certainly not something that the occasional surgeon should be doing, but we are getting the benefit of trying to preserve nephrons. And we all know, the risks over time of developing renal failure later in life in those patients who've had nephrectomy early in childhood. So it's a controversial topic, and it's interesting that there was a majority support for nephron sparing surgery. So we go to the next slide.
Hi,
Any other
Michael?
comment? I can't see the audience, so.
Yeah, Michael, we have one question for you. Go ahead, Coca.
Yeah,
Yep.
I was asking myself, because I might do like a nephron sparing surgery, but do you do something different in the surgery, like if you're doing a testicular kind of partial surgery? I mean, do you wait for the frozen section or something to decide to go for all the kidney, or you're doing nephron sparing surgery up front in Wilms?
So most of these patients are over 6 months of age and will have had preoperative chemotherapy, but this particular patient did not. The approach that I use for nephron sparing surgery is the same that I use for syndromic patients or for patients with bilateral disease. So I don't do laparoscopic surgery for partial nephrectomy. I do an open operation. I mobilize the kidney, so I have control of the vessels. I don't occlude them for a polar tumor. I simply compress the kidney between fingers. We do intraoperative ultrasound to mark the margins of the tumor, and we try to leave a safe cuff around it. And of course, we would only do this knowing that we could leave at least 2/3 of the kidney behind.
All right, let's move on. We probably have to cut it short. So let's move on.
We're going to hold on the questions because we're pretty over time, so we'll just keep going. Go ahead, Michael.
Okay, a quick one. 18-month-old male, imaging showed a right mid upper pole mass. This patient was treated on a SIOP protocol, so received 4 weeks of VA therapy and had this preoperative imaging. So aware this is a group of COG surgeons, what would your surgical approach be? Further chemotherapy, an open radical nephrectomy, a laparoscopic nephrectomy, or a robotic nephrectomy?
Okay, Jose, you want to make a comment while we're waiting? No. It's okay on the last thing. Yeah.
I was just thinking about the previous case, and I see a lot of hope in nephron sparing surgery for unilateral Wilms and non-syndromic patients. But I'm just glad that you mentioned that this should be super selected patients, because it's going to be very difficult to demonstrate a benefit from that surgery, I think. This group of patients only has a 1% of end-stage renal failure. And we know we quote to ourselves the rates of hypertension or cardiovascular disease they get, but that might be the consequence of chemotherapy and not necessarily the loss of nephrons. So just a note of caution, and I'm happy that you, as a really skilled surgeon within a protocol, are bringing that up, but I have the fear that it's gonna take a long time before we can just generalize this knowledge to everyone. Just an opinion.
Yeah,
great points.
Absolutely, Jose. I think it's a murky area. I think this is not we have to weigh the oncological risk here. We know that this type of Wilms tumor is imminently curable with standard therapy, and an open radical nephrectomy is a very good operation to cure it. So we have to be cognizant of that risk.
Can we see the poll? You can just, what were the percentages? We can just read them off.
Yeah.
Oh, here we go.
64% had open nephrectomy.
Yeah. Okay, and that would be entirely inspected, and obviously a very reasonable approach. Go to the next slide. One of the advantages of being in a PSYOP centre is that with patients treated with preoperative chemotherapy, it does two things. One is that it shrinks tumours, so they're obviously smaller. The second is that it definitely makes them more robust. They become a lot more rubbery, they're a lot easier to handle. And that does open up potential for minimally invasive surgery. So we all know the advantages of minimally invasive surgery. We also know the risks. These are the standard PSYOP criteria for minimally invasive surgery in Wilms tumor at present. I think when we're doing minimally invasive surgery for Wilms tumor, there are two main risks. The first risk is the risk of rupture, and it can be difficult to know how much you can move tumors or kidneys around with minimally invasive surgery when you have a tumor that you desperately do not want to get any rupture from. But they are remarkably robust after chemotherapy, and I think in our series here at the Royal Children's, we haven't had any ruptures during the laparoscopic nephrectomy.
Hey, Michael,
I think the second issue is lymph.
Go ahead. After this point, we're out of time. But what I would love, and I know you have a bunch more polls. Can you do us a favor and give us the upshot? Give us what are the high yield points that you were going to be making that we need to know with Wilms?
Right. So minimally invasive surgery is a good option for patients treated with preoperative chemotherapy, but it's difficult to do an adequate lymph node resection, and I think you have to be doing a lot of procedures to get good at that. The third case that I was going to show was about lymph node dissection and the areas of importance for taking them out. I think the crucial message.
Do you want us to show that? Because that's like a visual thing.
So sure.
Let's go to the slides.
Picture.
Yeah, and then he'll tell you which slides to go to, Isla.
There's a picture with ICG if you keep.
Yeah, go ahead.
Yeah. Perhaps we just go to the second to last slide.
Keep going.
Yeah. The previous one. So the simple thing about this is a really elegant study from India that looked at which nodes are important to sample, and it highlights the importance of taking the aortocaval nodes. And I think that is the difficulty at laparoscopic nephrectomy. Most surgeons who do minimally invasive surgery can do a laparoscopic nephrectomy, but it's the nodal dissection that is challenging, especially in that aortocaval area. And that's why this study was shown is very important to show that that's actually a crucial area. In terms of the number of nodes, I heard, I think, mention of 5 earlier in the session. In PSYOP studies, it's a minimum of 6. And going forward, we really aim to get more than that, so 7 to 10. And I think that's just because with preoperative chemotherapy, some microscopic metastases can actually disappear. So we need perhaps a slightly better, even a greater number really than COG. And just the last slide.
Isla, keep going. Keep going.
This is just about IC. Oh. Second to last slide. This is just to show some work about ICG, which I think is a real adjunct to show the location of lymph nodes during dissection for Wilms tumor. So I don't know how many surgeons are utilizing this. This is something that we've started using, and I think this is a nice demonstration of how important those aortocaval nodes are. Actually, see the green lighting up between the aorta and the cava.
So, Michael, what dose are you injecting, and where are you injecting this?
We have only it's expensive equipment, so we've only just purchased it here at RCH. So I have not used it for this.
Anybody here?
But I know that
Tim, are you using this?
you know,
We have,
Yeah, so the St. Jude group is doing a clinical trial called Visceral X that we're about to start enrollment on, but you use an angiocath without a needle to infiltrate it into the soft tissues of the kidney, so it's a direct injection into the soft tissues to do it. Some people will do it with the needle into normal parenchyma around the tumor if you have a rim of normal tumor, but probably the safest thing is to just infiltrate with an angiocath, a small dose that I don't remember off the top of my head.
so what I would suggest, there's going to be, when we go this fast, rapid fire, a lot of questions pop up. That's what chat's for. So if you could put in there some of the details you were just describing, so if people have specific questions, keep the discussion going in the chat. This does typically happen. If there's details you want to know, the chat can continue on about these topics while we move on. Do you want to make some final?
Yeah, the only other thing I was going to say is, like, of all the topics in our field, there's amazing resources for oncology. So there's seminars in pediatric surgery, have clinical guidelines. I'll give a shout out to Jenny Aldrich. She did the Wilms tumor one. All the major tumor groups are there. The Stay Current app, APSA library. There's some really good stuff out there to review.
That's a great point. And we have to be better with making sure we know where all these resources are and get access to them.
Yeah. One final plug-in
Yeah.
for the surgical, just so we push ourselves some more for IVC thrombi and thrombosis that's extending into the area. You can mobilize the diaphragm from the suprahepatic cava. You can make a pericardial window. You can put your clamp up there. If you've done a transplant rotation, this is just routine clamps, vascular isolation. So not everyone needs to go on a bypass for atrial thrombus unless it's attached to the valves or something. Hopefully we'll have a collection of patients soon, but we've done extensive diaphragmatic mobilizations and put in clamps up in the pericardial area.
And we can put the ICG information in the chat.
Yeah, if you could do that, if everyone can just, any resources anyone has, this is a great pool to throw your resources, be generous with your, anything you know that would help the rest of the world, we'd love those. Phenomenal session. This is one that probably needed twice the amount of time. Michael, I don't even know what time it is there. What time is it in Melbourne right now?
It's 12:30.
Oh, man. All right. Well, thank you. I hope you can sleep in a little bit tomorrow, but thank you so much for joining us. This was so much fun.
It's been fun. Thank you for asking me. I think this is a great event, and it's really good to sort of open it up to the rest of the world.
Thank you so much. Thank you. Thanks, Bhargava and Justin. Thanks, everybody. Great session. All right, so we shortened the break, obviously. So what is it now? Just a few minute, 5 minute? 5 minute break. Hurry up. And then we'll come back in 5 minutes.
I got a call from his pediatrician. He just said, I am so sorry, but there's a very large tumor in Atticus's brain. We would go to the ends of the earth for our child, and it was the obvious decision to take him to Cincinnati Children's for his cancer care. It required us to travel from Nashville to Cincinnati. Cincinnati Children's is the one that helped save Atticus's life, and we are so thankful.
I get to ask the kids beforehand or the family beforehand if they have a particular interest, a cartoon or sports or something. Do we come up with
What do you want your bandage to be?
The Flash running through.
The Flash?
Mm-hmm.
Cool, like Flash, like the cartoon Flash?
Or something with lightning.
Okay, something with lightning, done deal. At the end of a case, as everyone's kind of finishing up, I'm not hovering over everybody. I can help make this dressing kind of thing. And everybody kind of gets into it. I have a whole set of pens and pencils and stuff, and we make these things. But basically,
When you're operating on a baby, you're impacting the rest of their life. So if things don't go well or you have problems, it could affect the rest of their life and how they develop and grow and go out into the world. So to have the right size tools that are finely crafted and are surgically precise is incredibly important. Without those tools, it would be incredibly difficult, if not impossible, to do it. Dr. Storz, Sybil Storz, had an incredible commitment to the children of the world, and she invested huge amounts of time and money to help develop the instrumentation and to do the training that we needed to train pediatric surgeons all over the world. And I think that commitment stands for a lot. It is a pediatric portfolio. It goes the entire spectrum of pediatric subspecialty care. So it's a total solution.
We like to use a NIM tube. That's part of trying to prevent potential injury to recurrent nerves, or at least make you aware when you're getting close to them. It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Now that we understand the standard workup and OR setup, let's dive into the typical approach of Dr. Dialarcon's team.
It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Sometimes they can assist with the thoracoscopic approach by removing some of the residual or regrown large thymus because it's right in the way.
Did you know that State Current has an entire video library on surgical technique videos? Today, we are highlighting a laparoscopic orchiopexy. Today, we are highlighting a thoracoscopic repair of a Boschel-like hernia.
Hey, there you are. I just got the call. 5-year-old male pulled from a house fire. Vitals are listed here. What should we do first? All right, airway's intact. Breath sounds are equal and present bilaterally.
For this issue, we talked to Dr. Colin Martin. He is the publication chair and the editor of this issue.
In this case, it was very obviously, and it was seen on ultrasound, that there was no septum and that there was a huge cyst.
Hey, pediatric surgery. So here's another article that you probably want to know about.
The authors here wanted to take a look at preventive fundoplication for patients undergoing repair for a congenital diaphragmatic hernia.
We don't have much time, so let's start.
In this study, the authors reviewed their experience with laparoscopic common bile duct exploration with balloon sphincteroplasty for patients with pediatric choledocholithiasis. This was a retrospective review at their institution between 2018 and 2021.
For more than 65 years, Oishei Children's Hospital has specialized in the surgical care of newborns, children, adolescents, and young adults. Oishei is the only hospital in Western New York with 24/7 access to pediatric surgical subspecialties.
That includes pediatric plastic surgery, ENT surgery, ophthalmology surgery, oral maxillofacial surgery and pediatric dentistry, general surgery, thoracic surgery, orthopedic surgery, neurosurgery, and pediatric urology.
We treat all children for most common problems, trauma. Cancer is a problem, but we provide a full
worldwide, which shows you how much we're craving better ways of doing things, especially like that. So it's time for an update because it's been many years since we've done it. So to do this, we have Dr. Whit Holcomb, who I told you helped conceive this whole event idea, this whole update course. Whit is the editor-in-chief of the Journal of Pediatric Surgery. Probably a couple of you have heard of that journal. Also, is the editor of the textbook that I've always used, and now Sean's on that. From Kansas City, and now lives in, where do you live, Nashville? Nashville, and he's gonna be hosting this with Dr. Nelson Rosen, who is one of my partners in Cincinnati, and a very advanced colorectal surgeon, and they're gonna be talking about all the updates in Pilonidal. Thanks, guys.
So I'll be brief, but I find this an interesting topic because there are a number of papers we get at the Journal of Pediatric Surgery on this topic. And I must tell you that I'm of a generation that no one would have thought about doing a minimally invasive technique to fix a pilonidal cyst or pilonidal disease. So I think it's very interesting because you're going from sort of maximally invasive treatment to minimally invasive treatment. So I'm going to let Nelson take over because he knows much more about this topic than I do, and I'll chime in with a question or two as he goes along.
That's great, thanks. Can we have the next slide? Okay, so let's start with a poll. So you have a 17-year-old male, this is what you're looking at, and they tell you, well, like I'm bleeding. You know, most people can't see what their bottom looks like, so they know what they see in the underwear, and they have this, oh, I'm bleeding, some drainage, and they often describe it that way, and pain on sitting in this exam. So what's your next step? And I'm not asking for your ultimate step, but what's your next step?
All right. Comments,
Hold mic closer. Yeah. Sorry about that.
Anyone have comments on this before we show the polls? Personal preferences?
So if I could ask Nelson a question.
Yeah.
I think it might be important to explain minimally severe disease, you know, maximally severe disease. Does it matter in which treatment option that you look at?
It's a great question, and it something we're actually looking at right now. You know, how do you define severity in pilonidal? And there's not a lot of science on that. Like there are people that have put out staging systems. And these staging systems are, some of them it's my great idea, like, oh, I make classifications, but not all these classifications correlate with how they do. They don't always correlate with how you need to start your choice of intervention. So the one thing that I can tell you that's shaking out from our looking at our own data is that patients with wounds, presenting with wounds as their initial presentation for pilonidal, tend to not always get to the finish line fully healed with a minimally invasive approach. So that's one thing to think about.
At least that's a starting point.
It is some starting point there. All right, so we have answers on the poll. It looks like people are jumping right to minimally invasive pilonidal surgery. Wide excision and packing is pretty small. Some people are, a third of you are starting with shaving and meticulous hygiene alone. And then some people jumping right to the wide excision with off midline flap closure. All right, next slide, please.
Comments are coming in already.
I love this and I use this routinely. I think it's all about the conversation you have with the patient and the patient context. I've got a 16-year-old baseball player, and it's like March, and they're getting ready to start their season, and they're miserable. Then we're going to go to the operating room. But I also say, 60 to 70% of the time, it works every time. And you set that expectation bar that this may be, you may get partial healing, especially depending on the severity of disease, but that you may have to go back to the well. But it's not going to be something that takes them out of season or takes them out of their activities of daily living, because they're going to be able to go right back to it by and large.
Right, and I like your numbers, that 60 to 70% works every time. I think those are probably some real honest numbers there, as opposed to what's published out there when you look at some very rosy reports. But for this, I was going with this is green level. And I think if you're not pushing hair removal and meticulous hygiene to do the best that you can, you're probably going to end up operating on some people that might not need an operation. But again, you have to talk to your patient. There's some people that no matter how many times you say, you should shower, you should bathe, you should get the hair out of there, they come back to the office and it looks the same when you first met them before you cleaned them up the first time. But if you could flick the slide, there's I think I'd pop up. Right, so these reports go back a long ways. Like John Armstrong, in the United States Army had a clinic where it's a captive audience and they just shaved their patients every week. And they really found a dramatic improvement and not a lot of need for surgery. But if you look, just a large percentage of patients will be healed with non-surgical measures alone. So I really do think that it's a good starting point. And I can't tell you how many people have come to me from hospital and hospital and hospital, and they're full of hair tufts sticking out of holes, and nobody clipped them in the office, nobody removed the hair, nobody mentioned that hair had anything to do with the problem of pilonidal. We use the term nest of hairs, but if you're not getting the hair out of there for the patients that have hair as a part of the issue, then you're not doing all you could do.
Can you comment on techniques for hair removal and hygiene, shaving versus Nair type agents or laser hair removal, or maybe you're going to get to that? I don't know.
Right. Well, I have the adjunct to my slide here that talks about I think on the last slide I had a picture of the clipper. So on this slide I have a picture of Nair. And so many people will struggle with that. A lot of our patients are teenagers or people going to college, and sometimes they don't have anybody to help with them. If there's a parent, an active caregiver involved, then the clipping we think is probably the easiest, simplest thing to do, and have somebody once a week do it. If you struggle, you can come into our office. But for the college student who lives alone and doesn't have a friend to say, hey, I feel comfortable with you clipping my bottom. Right, that's not going to happen. Then Nair, and so we do also recommend that.
I will routinely, when my patients are in the operating room, I'll have parents bring in wax strips.
Yeah.
And we'll all sit there during the prep verification and the timeout and be warming up those wax strips, and we will give them a really good head start in getting that entire natal cleft area and the buttocks on both sides free of hair, to give them this is the expectation. When they come out of the operating room, they should have this sort of degree of hair removal, whether it's clippers thereon, but it's a great time to get a wax is when you're under general anesthesia.
That's amazing. I hadn't thought of using wax strips in the office. One of the things I did have on there, some other adjuncts like showering, the hand shower, I think very important. People actually putting water in there. I can't tell you how many people said, well, they told me I couldn't bathe. And I'm so confused because wounds love water, and if you don't wash, then you're probably not going to heal anything. So we talk about all these adjuncts, including washlets for people who struggle to clean their bottom after having a bowel movement. So all of that goes into the education piece. All right, but let's, I know we're pushing for time, so moving on. The poll. They're doing their best with hygiene. They're doing their best with hair removal. And now, what is your next step? Ongoing symptoms, what's your next step? I got wide excision and pack, wide excision midline closure, wide excision off midline flap closure, and then minimally invasive. And I'm particularly vague on what that phrase means, because it means different things to different people.
Just while we're waiting for the poll to come up, so even that first picture you showed, you would still start with the hair removal?
I would, absolutely.
Because it looked pretty severe.
It's pretty severe,
I mean,
but if you clip them, you get the hair out of there. Some of those patients, again, depending on the extent that symptoms are disabling from their lives, some of those patients will actually do okay without a surgical intervention.
Okay.
All right, let's see the results. We got over half are jumping to a minimally invasive. Okay. Wide excision and packing, there are still people doing that. I suspect worldwide that is probably the most common operation that happens. You know, there's still a bulk of pilonidal work is not done by people who are doing advanced pilonidal work.
So when you use the medical treatment, hair removal, and do you add in those cases the nasty ones antibiotics for a while or nothing?
I don't put people on antibiotics unless they're coming in with an active infection. When they have painful cellulitis, and that's a subset because some people don't drain very effectively. And those are the people that have the most minimal external manifestation. They have like horrible pain and a big bulging abscess and almost nothing visible there. But the people that have all these holes, they drain. They don't come in with pain. They don't come in with those types of infections,
All right, why don't we go on, Nelson?
Yeah. All right, so next slide. Here's my answer slide. Yeah, so that's not exactly my answer. So that's an acceptable answer. I really do think that if you look at it, wide excision and packing wounds is probably not the way to go. It's got a very high failure rate. It's extremely challenging for patients and families, and we just really think that it's not a good solution in 2024. The wide excision and midline closure, there are people that are still doing that, and we see a lot of those patients come to us struggling with recurrent disease and ongoing disease. There seems to be that the wide excision with off midline closure, which is really goes back to the 60s when Carrie Dacus first described that, and then John Bascom, but the Limburg flap has been used since like the 40s. These are old operations, but they do work. But the minimally invasive, now that most of us know about that, we really do think that that's the best answer here and the starting point. And then ironically, you talk about like the older generation would never have thought of doing that, except like for those are my international colleagues who come from Commonwealth nations that Lord and Millar described this in 1965. It's really the same, almost the same operation that Moshe Gibbs described with his big article in 2008. So it's been out there for a while, just people haven't adopted it. But it seems to do very, very well. You look at Dr. Gibbs's study, they had a 15% recurrence rate over 10 years. What I found in our practice is that we have not been able to match those numbers. Our numbers are a lot closer to the 70-75% range, where one minimally invasive operation gets you to full healing and a lasting recurrence-free healing. Let's see the next slide there. Yeah, so now other adjuncts to minimally invasive clean out. And again, the wording I think matters here because like people think of like, well, in my operation, I use a 1470 nanometer laser probe to ablate the tracts. That is an operation, but those operations usually all start with clipping, washing, getting all the hair out of there. So they're very, very similar to all the steps of a minimally invasive, what some people would call a Gibbs procedure in the first place. But there are people doing laser diode tract ablation. There are people putting phenol in there to sclerose the tracts, fibrin glue, and all of these have proponents, but none of them have been proven superior. So,
all right, well, Got about 5 minutes left. Why don't we go ahead?
I have a question. I'm out here. So it seems to me that we are lumping all pilonidal disease together when maybe there are different phases of presentation. So what you presented was like kind of a chronic wound, multiple pits. What about a patient that just presents with an abscess and maybe one pit and not a lot of hair? Are you going to offer them a MIPE also?
So for somebody, first abscess, we drain them, we take a look and we see what we're dealing with, and then we put it to the patient actually. We tend to be very quick to offer minimally invasive approaches because it really is a 20-minute intervention under sedation in our place with no activity restriction and no narcotic requirement. So we're pretty aggressive about offering that. Again, we are surgeons, so that's how we start.
You showed a picture with like 8 to 10 pits. When you do a GIPS, how many of those pits are you actually excising?
All of them.
So that's a elliptical wound at that point, right? Because you can't, if there's 8 of them right in a row, you can't individually leave a bridge between those.
Well, that one, that's a tough one. But most of the time you can get acceptable skin bridges and not create somebody to a large open midline wound. Yeah.
And sometimes if they're close enough together, you can get 2 with one punch.
Right.
And have less overall wounds.
Yeah, that's the art of doing the GIPS procedure, I think, is trying to maximize those skin bridges and not give somebody a big wound.
So why don't you just briefly explain to the worldwide audience what the GIPS procedure is?
Right. It's basically using circular punches to punch out the holes and then going through the opening, scraping out the internal cavity, getting all the inflammation and all the hair out of there, necrotic fat, and then leaving them open to heal. But I think we should, if we fly through, then we can hit any other questions. But EPSIT, this was described in 2013, doing it all through a small incision and putting a big scope down there. That scope is not available in the United States. Next slide. So I started doing what I call a hybrid GIPS. An 8 French cystoscope is available in most institutions, so once I cleaned everything out, I put a scope just into the openings from a diagnostic point of view to make sure we got out all the hair, and we've been doing that for the past 5 years, and we're quite happy with it. Next slide. Yeah, so this is, again, like GIPS, again, Aaron presenting 10 years ago, and really, GIPS is not new. And so, honestly, green level, if we're not starting out with minimally invasive as our first surgical intervention for most people, we really should be.
I want to emphasize that. This is green as green gets. Like, I'm going to be adamant and provocative to say, if you're not doing this, you're doing it wrong. I'm going to be that provocative. Okay? Is there anyone that challenges that? Because this is just wrong if you're not doing this. Wow.
No, I think you're right on, Todd.
Was the mic off that whole time?
But these are actually 2 of the things that I've really learned about in the past 6 months or 8 months or something, and so I think these are new. Roland Anderson in 2017, Swedish study, they did 113 patients where they did a minimally invasive approach, and he suture closes all but one hole, which he leaves open to drain, and they had excellent results.
Top one or bottom one?
What's that?
Top one or bottom one?
I think top one. I think he's leaving the top one. I would not leave any bottom hole open if I was closing. Yeah. Always, that lower down is always harder to heal than higher up in the cleft. So this is a great question. Should we be suturing our openings? And then the second thing is that nationwide they did this very large prospective study on laser hair removal after surgery, and they found that it significantly reduced recurrent disease. And this is the first randomized prospective study on this subject. There's been like little case reports here, small series, retrospective review, and anybody who has ever worked with a patient on this knows that the insurance companies will do anything to avoid paying it, even if it means that they're going to pick up a $5,000 emergency room bill when the patient comes back with an abscess. So as we say, penny wise, pound foolish on the part of the third-party payers. But I think that we should be getting all our patients to laser once they're healed.
So Nelson.
Yeah.
So just want to say I haven't found the scope useful, like at all, in comparison to just doing the punch with the circle stuff. The other thing I found very useful to use, I haven't used
the scope useful, just my experience. I found very useful to use the metal probe just to get the direction of the sinus. Otherwise, you just kind of chunk a hole in the middle communicating with the big cavity instead of doing a proper sinusectomy. And I've also changed my dressing. When I was doing flaps, I would keep a very occluded dressing, ask the patient to lay on their tummy for a few days, not to touch anything. And actually, now I encourage quite the opposite. Like if they're laying on top of the wound, they're obliterating the remaining cavity, and they're kind of getting all that fluid out. I don't know if you've done anything like that.
You know, we basically have them to their own devices for wound care, and we just have them keep a gauze roll in the cleft, and it keeps the cleft from burying the opening so that they can drain while the thing is closing up. In terms of the scope, like, I like the scope. I don't think that the scope, like if we really would look at it, would be like a huge evidence-based measure. It maybe makes me a little bit lazier from the perspective of, like, I don't spend too much time scraping before I put in the scope and take a look. And like, oh, I missed hair here and missed hair here, and then we can just focus the effort. So it also helps irrigation. You know, I think it's a nice adjunct, but again, I agree, it's not essential.
So another comment, and then we have like 1 minute left, so yeah.
Yeah, so I have a comment related to Pete's paper, but also the fact that, you know, I've tried to be somebody that cures this disease too. We all have our moments. And so I've had a patient come back at 6 months, and, you know, you think you've had a 6-month cure, and then there's this granuloma. He's got some drainage, he's got some blood. So what happens, though, is the life cycle of these things is not, you know, it's long. So what you need to do is actually do the laser hair removal probably over and over again. We just started waxing, or he started waxing after that. And there again, we've got another cure for how long it takes, again, to regrow the hair. So the question is, how long do you tell patients they need to be attentive to the nair, the waxing, or the laser throughout their adolescence or into young adulthood?
Yeah, but into adulthood, definitely. You know, the longer they can sustain it, the better. Laser is not permanent, but it certainly knocks it down to a lower level. Yeah.
John?
I send my patients to Amazon, where you can buy a laser hair removal device for about $150. So if insurance companies don't pay it, there are very affordable options. It did for that patient, it did, yeah.
Yeah. And then I think maybe we go to the last slide. Yeah, that just shows my graduated treatment approach, our graduated treatment approach. Like, for patients that 1 or 2 minimally invasive approaches did not work and they have significant ongoing symptoms, which is important. You have to really push it back to that. If they're like, well, no, doc, I'm good, like, well, then okay. But if they have ongoing symptoms, we move to an off midline closure, and our choice is a Bascom cleft lift. Next slide there. And then check out the International Pilonidal Society. If you do a fair amount of this work, it's a great group. It's free to join. Like the meeting, there's like a meeting every other year. So that's where you can meet with other people that do a lot of this, and it's fun. You find out the ideas from others who are sharing your struggle. Next slide. And I think that's all I got.
Great.
Thank you.
Great.
Awesome. Thank you guys so much. This was great.
Great job.
All right. I think a lot of us were blown away that there was a society for this. I had no idea. So, all right. From pilonidal to CDH and ECMO. We've got, it's not quite international, but Seattle. It's like, we have Rebecca Stark and Stephen Lee coming from Seattle Children's. And it's about CDH, but also the role of ECMO and timing of ECMO. So we'll see what we can learn today. Thanks, guys.
Great. The travel here seemed like it was an international trip, so we missed last night's event. So don't you love pediatric surgery? We went from choledochal lithiasis to Wilms to pilonidal, now to CDH. So just some variations on the spectrum of diseases. So I'm going to hand it over to Dr. Stark to get started.
Hi, I'm so excited to be here, although a bit nervous. This is my favorite thing to talk about, and this is going to be very controversial because the disease itself is controversial, so that's my disclaimer. That's my disclaimer. We'll see how people feel about these questions and my answers. Okay, next slide, please. These are the two basic things that we're going to be talking about. when and how to do ECMO to treat CDH, and also when to repair and how to repair. And I'll talk about anticoagulation at the same time. Next slide, please. So this is our first clinical scenario. I purposely made it a little controversial. So full-term neonate, known diagnosis of a left-sided very severe CDH. You can see the numbers up there. Less than 25% for each of those are severe, so this is a very severe CDH. No known cardiac anomalies, no genetic anomalies, delivered about an hour ago. Let's say it's an inborn situation, intubated and resuscitated per your institutional protocol. So we're not going to go into vent settings, nothing like that. Just imagine you trust your protocol. These are the first vitals. So preductal sats are in the 70s, heart rate is 150, blood pressure is 35/25 on 100% FiO2. This is your first gas, so pH is 6.8, PaCO2 is 130, and PaO2 is 28. So then I'm going to ask, what is your next move for this patient? And we can talk about each of these answers, and I wonder if some audience members would like to say what they would do at their institution.
All right, so while we're waiting for the polls, I know people are strongly opinionated about this.
Yes. Forgive me in advance.
Anyone want to make a comment on their preference, thoughts on this? Have they changed their practice? Mac? No, you. Why me? Give yours.
Okay, don't pick D. Don't pick D.
So I have to read the thing again because I wasn't really paying
Okay,
attention.
I don't have to put you on the. Okay, anyone else want to answer?
Jose, what would you do in Chile?
So in Chile, there's one big neonatal ECMO center that takes care of all of these babies. They usually put babies in ECMO with an oxygenation index over 40, and after reassessment of.
Sure.
So usually they do first VAFO and nitric oxide before putting someone in ECMO. And also, you usually want to see a oxygen saturation above 80 at some point before putting someone on ECMO. So I think, well, maybe I'll take the Todd Polsky approach. Maybe this will be wrong, but I'll take some time and reassess.
Yeah.
Katie, what would you do in Utah?
I mean, I think that kid is, we know from the prenatal parameters that the child is definitely at risk for ECMO. I think our rates of ECMO have gone down dramatically over the years, and we're at less than 10% overall. But I think that is likely a kid that would go on ECMO, and our strategy is to go on VV first, with the ability to convert to VA if we decide that's necessary.
And I would be the old school person that still does VA because I'm not bold enough to go VV.
It's not that old school, actually. you will see, but
Is it?
Yeah, I mean, the vast majority of centers that report to the CDH study group, so like over 90 centers, thousands of patients, do VA ECMO. But can I have the next slide? Quickly, just to talk about A and B, they're basically equivocal in terms of outcomes, so there's not a survival difference. Proponents of VV, there are lots of benefits to VV, there are lots of benefits to VA. The majority of centers, as I said, still do VA ECMO primarily for CDH babies, and there is a conversion rate. So it's both answers are totally reasonable. I think the baby needs an intervention. I think you know from the prenatal imaging that the baby is is at a high risk for needing ECMO, and I think the time to intervene is probably earlier rather than later.
Do you feel that VV cannula availability and also concerns with certain VV cannulas has played a role in that, and now that there are different cannulas available for VV, do you think those numbers will change?
I think it's possible. I think the other thing that people really think about with VV is size of the venous cannula. And some of these babies we know have smaller vessels than their normal cohort. And so I think that is part of the question. I do think that if you were at an institution that did VV and you couldn't cannulate because the 13 French is just too big, you'd probably do VA. And I do think that there are better cannulas coming out, and that this is something that the needle might move on. Things move very fast, as I'll show you in this world of CDH, where one day you have everyone doing VA, and you can take a poll 2 years later, and everyone's converted to VV. So it's definitely a moving target. In terms of C, I definitely don't think that is a totally incorrect answer. There are lots of protocols that I've seen that take time to reassess, and ECMO cannulation within the first hour is a really hard thing for people to decide to do. I will tell you that there's data from the study group, so big numbers, that show that high performance centers cannulate earlier on lower event settings than other places. So they're getting higher survival, and that's the main thing that's unique to all of those protocols. So I think this baby doesn't need more time. You could reassess if there was a big thing you could change. So you look at the chest x-ray and the ET tube is almost out, or it's really main stemmed, or there's something that could make a big difference. Please intervene, reassess. But if event change isn't going to help this baby's kind of too far. And then in terms of comfort care, there is a lot of data, especially within the last 5 years, that really supports trying to get survivors out of all of these babies, mostly because we don't have a great way of deciding which babies will survive and which babies don't survive. And if we had a really good way of figuring that out, then it would make sense to not offer ECMO to some patient populations, or if you're in a place where you can't offer ECMO readily, you have to transfer babies many hours or those sorts of things, then some of these, if you can go to the next slide, some of these ideas about screening before you put babies on ECMO makes sense to me. And it all comes from a really good place. It is a struggle to have babies die on ECMO. It's hard for the families, it's hard for the care providers, but I do think that, and next slide, I won't go through all of these, sorry. This paper is really good, and it really drives home this point. So, at Michigan, they had a SPHERE protocol. That protocol helped them decide which babies to offer comfort care to and which babies to offer ECMO to. They were prenatally selected, so you can see the parameters here. If they had a severe CDH, so all of the normal qualifications for severe CDH with liver up, the parents were educated that they would go on this pathway. In the delivery room, they had ECMO on standby. They would intubate, they would do ventilation. Also, needle has moved on this, and it is not considered gentle ventilation anymore, and be resuscitated. Within 2 hours, if the pH did not meet 7, PCO2 wasn't less than 100, preductal sats weren't above 80, they were offered comfort measures only. And if they could achieve some of those things, they were offered ECMO. So to analyze this, Aaron Prony actually looked at the study group database, got lots of numbers, was able to get 2 groups of patients that exactly matched these 2 clinical scenarios. And so the failed group is the group that was offered comfort measures, so didn't meet any of those criteria. And the success group was offered ECMO. She compared these 2 groups of patients. They had equivalent survival amongst those 2 groups. That means that half of the patients that were being offered comfort measures could have been survivors. It also means that half of the patients that were offered ECMO didn't survive. So we are really bad at choosing. And if you make this decision to choose beforehand, you're going to be wrong 50% of the time. And I really strongly believe that. We've all had clinical scenarios where you don't expect a baby with CDH to live, and they live. And we've had scenarios where you expect a CDH to die, opposite, survive, exactly. And so I feel very passionate about this. I know it's controversial, but I do think that if you had good prenatal counseling with the parents and they are all in for this, you should pursue ECMO for every unilateral isolated CDH. So I'm not talking about genetic syndromes, cardiac syndromes. That's a whole different ballgame. This is an isolated unilateral CDH. So now you have another clinical scenario. Thank you for moving me along. This is the same baby, and you've placed the baby on VA ECMO. And what anticoagulant are you going to be using? What does your institution use? What do you think? You can move the slide forward to show the answers. Yes. I put other, but I don't even know what other is. I just wanted a 4th answer.
We use bivalve.
Yes. Oh, great. Yeah, we use bivalve as well. Do you like it?
Yeah, we love it. I think one thing you can get out of the mind is you never have to worry about HIT. You never have to worry about following 83. It's really a struggle always getting heparin into even if you're in a subtherapeutic or therapeutic range. Bivalve is pretty much a no-brainer, and we use predominantly as the sole anticoagulant drip for most things.
My gosh, I love that you're saying that. Is this a black diamond, or is this like a...
Me, everything's a black diamond.
No, I think most places still use heparin, but I think this is one of those times when the needle is like really moving quickly because a lot of places are switching to bivalirudin as an. Yes.
Is this a black diamond, or like, is that the correct answer?
I think you cannot say that because it's some institutions will not offer bival, and that's something you can't change in your own institution. So you're going to use heparin, but I will say there are a lot of benefits to bivalirudin. You know that it's a little bit more expensive, but the benefits actually outweigh that cost because you give less blood transfusions. Everything is better about it, and I think people, once you try it, will switch pretty quickly. But heparin is still the most commonly used, although a lot of places have switched.
Okay, so most of the world.
See,
agrees
but
with
that's way more than 2 years ago when we did a poll.
Yeah, but that was after Bhargava said.
Oh, okay.
So
okay.
he swayed the
Sorry.
audience.
You know, I forgot to look at the audience poll for the first question. Okay.
I mean, in the room here, I mean, Greg, what do we do? Oh, yeah, we do bival.
Yeah. Yes, that's exactly what happened. They were using it for LVADs at our institution, so it was really easy to switch over. Next slide. This is the protocol that kind of came out really early on, and people started adopting pretty quickly. Next slide. In that prior paper, you know, they use PTT to monitor bival level, and this is a paper that came out of our institution. You know, like I said, we were using it historically for LVADs, and so they had to figure out a way to really track bival levels. You can do it with a dilute thrombin time. Any lab can create this. It's 5 times more specific and sensitive as PTT, and so it's something that we can share, and it's a great way to monitor the bival levels as you go through. I will just say 2 more things, or maybe 3 more things about bival. It has a very short half-life, so it's really easy to turn on and off. You see immediate effects. It's like a 20-minute half-life, and it is something that there is much less variability between patients in terms of how effective it is at anticoagulation. Let's move on, because I have a lot more slides. This is just our protocol. You can go through it. Okay, so now, the same baby, severe CDH on ECMO, you're using bival, when are you going to repair? So can you move the slide forward to the answers? Okay. So what are people doing in this room?
Early repair. Early.
Wait, did you say late, Sean?
A, yeah.
Oh, A, okay. Yes. Anyone doing later repair?
A or B. So no one else is repairing late, or if they can't come off ECMO, not repairing. So maybe this could be like, you got to do it. Because people are still doing D.
Yeah. Oh,
let's look at the poll.
Yeah, I keep forgetting these polls.
So.
It's definitely controversial at my place.
Yes. It is controversial.
You know, I already said, like, we've really decreased our ECMO rate, like, dramatically. But I definitely think there are very vocal voices at my institution that would wait weeks before repairing.
Okay.
I would say repair. The 48-hour window is nice because the ECMO circuit gets broken in. You give time to get it broken in. You give time to give product. You give time to all those fluid shifts to kind of start to clear themselves. You don't wait so long to the baby. It looks like the Michelin baby. And it just, I think that's the time to do it. You've already got a broken in circuit. Hopefully not a lot of clot burden. You can turn off your bivalve, you know.
Or
start,
not.
Yeah, start your Amicar.
I would say don't give Amicar. Don't turn off the bivalve, just turn it down.
I mean, but whatever you do, you got like a broken in circuit and you got a baby that's not too, and you just start to fix things and start to move things forward.
So I remember this discussion about 10 or 15 years ago at our institution. And I remember somebody brought up a really good point. At least at our institution, the neonatologists were actually running the ECMO. So if we repaired them early, then we didn't have to get calls from neonatologists telling us about all these problems with ECMO or the hernia, when are you going to fix the hernia. So it actually streamlined our approach. We would fix them early, and then the neonatologist could manage the rest of them.
I want to just bring up one thing. I think in this room we have experts from major institutions and so forth, and going back to what your institution offers. And there are many institutions that are lower volume where neonatologists are very involved with the care, and switching to an early repair, if you're only putting 1 or 2 children on ECMO per year for CDH, is a challenge, and you need a whole buy-in. So the question is, how do you get this buy-in? What kind of protocols, and how do you ease this
People into
transition?
it. Well, I think you show a lot of data. Luckily, we were already using BiVal for our LVAD, so that was a kind of easy transition. And then you really build a team. So we have anesthesiologists who do our repairs on ECMO. There are 2 of them. They do almost all of the repairs on ECMO. You get buy-in from the neonatologist who's running the pump to be with you in the operating room so they can manage those levels at the same time. And you get people to agree to operate on weekends sometimes, because what I would just say is, if you use BiVal, you don't have to wait for the circuit to kind of equilibrate. It's very fast. You can operate after 8 hours of putting them on BiVal as long as your levels are stable, which happens really soon. And it's a much easier surgical repair. There's very little edema, no edema. It's very similar to doing a repair off ECMO. So I have 2 minutes left, so I just want to say the one thing I would not say is all these babies should have an opportunity to be repaired. You know that if you don't repair them, even if you're waiting till the end of the run, that they're not going to survive. So if you were trying to get as many survivors as possible, you should offer repair. The other thing I will just mention is that there are groups out there that actually risk stratify once they go on to ECMO. So if the baby's high risk, they operate early. If they're lower risk, they try to come off and then repair. I think that's totally logical. The problem is you can't be 100% certain which babies will end up with a late repair because they can't come off ECMO, and that's really the worst time to operate. This is one of the papers that really popularized it. Okay, next slide. These are all the advantages, and I would love to tell you about all of them, but you get good lung growth. I think the cannula position thing is really important. It's something that, if you're 3 weeks on ECMO and that cannula is getting adjusted and moved and you're getting fluid for it, it can be really challenging. It's much easier if it's in the right position because the heart's in the right position. Left-sided heart disease is a big contributor to overall cardiac function. We know that now. You can't predict which babies can come off without repair reliably, and you are in a much better position to come off ECMO if you need to urgently, like you have a head bleed, you have bacteremia you can't clear. The baby's already repaired and you're 3 weeks in, you have a much better chance of survival coming off rather than coming off with a sick baby who still needs repair. And then it's very rare, but you still have this risk of volvulus and bowel ischemia the entire time you're on ECMO if all that bowel's in the chest. Next slide. Next slide. Okay, repair can be done safely. These are my take-home points. Early repair is technically easiest, and I think between 8 to 24 hours is really the right time. We use bivalrudin. We don't use Amicar. We turn down the rate. We can share our protocols, but I think that's what most centers are doing who use bivalrudin. And I think that it is helpful to have a smaller team doing the surgeries. It's very nice if they can be under, 2 hours, and you pay meticulous attention to the surgical operation. I do want to say there's a slide that got skipped that might be interesting to people because I, reached out to Matt Harding because I wanted to know out of the 90 centers that contribute to the CDH study group, which patients are getting early repair in this group, and now almost 80% of centers that contribute are doing early repair on ECMO. And if you could see this graph that I put in there, but I think it got skipped, it's pretty impressive. The data has shifted just over the last 3 years, and so it's an impressive shift, and I think that in the CDH world, you get shifts like that really quickly because if you're part of a big group of contributing centers, when someone's an early adopter and it works, you're able to pick up on that really quickly and try to move the needle. And so I think I will end there.
Okay. So, great. Yeah. So just really quickly, your last 2 endpoints, your 2 teaching points were what?
Oh, I think that if you have a very severe isolated unilateral CDH, you should consider them a survivor until they don't survive, and also that early repair on ECMO is safe and physiologically benefits the patient.
Great. This is phenomenal. Do you have guideline protocols that you guys use at your hospital?
We'd love to share.
Shareable?
Oh yeah.
Shareable?
Gosh,
that would
of course.
Be phenomenal. Any final comments or questions before we end this session? This was, as we knew, pretty provocative. All right. Oh, we do. Okay.
Sorry, hi. Thank you very much. I would like to ask you, do you have a minimum weight or
Yes.
minimum age for ECMO connection?
We use less than 32 weeks, less than 1.8 kilos. Those are relative contraindications, so if there were like particular reasons for or against, we don't say absolute, but those are our cutoffs. They're probably pretty similar to what other people are using at their institution.
Minimal invasive CDH repair. I find it really beautiful surgery and skilled hands, but have not seen a report giving equivalent results. What's your opinion on that? And are you doing it personally or as a group?
Equivalent results
In terms of recurrence.
Oh, recurrence rates. That's like such a big bag of. Because
That's gonna start a whole nother discussion.
Yeah, the needle is also moving on how to do the repair. Some places use
That's
patches, some places use muscle flaps, and so I think recurrence rates are different among those two things. And it's a great question. I would
We'll
love
do
to
that
talk to you about
next
it.
year.
Yeah, exactly.
Thank you. We'll be back. That was phenomenal. Thank you so much.
Yeah,
A lot of Thank you. All right, we're going to move on. We are staying relatively close to time, ish. All right. So the next topic is on ICG and its use in thyroid disease, and we got Justin again. I don't know how he made it up here to stage twice.
Well, the first one was going to be Mark Wolkan.
I know. Mark
was second
Wolkan
choice.
is getting married in a few days, and he's. What kind of excuse is that?
Yeah, kind of disappointing he chose that over
stepped in.
you, but.
But we're going to talk about ICG, and you want me to? We're going to show the rating score. Yeah. So, yeah, go ahead, Ben.
Hi, I'm Ben Ham, one of the pediatric surgeons at Oshai Children's Hospital.
Justin Item at Akron.
And we were initially asked to talk about ICG, but in doing some research in the literature about it, we also noticed some other groups have reported something a little different, so we chose to include it as well. And so we'll touch on both autofluorescence and ICG angiography. Next slide. And so both of these things can be used to help to identify the parathyroids, but then also to assess their perfusion. And so one of the things we think about in thyroid surgery is we want to preserve the parathyroids and decrease the risk of hypocalcemia and the need for calcium supplementation, both initially and over a long period of time. And so these are some adjuncts that we can use to try to help with that. So we want to start with this poll. What has been shown to improve rates of hypoparathyroidism or hypocalcemia after thyroidectomy?
Can we just see how many people do thyroid surgery in the room? Two? Three?
One, two, three, four,
Not
including
all-
us, 5, 6?
Yeah,
maybe.
us too. Yeah. So not a lot. Have you heard of this technology at all? If you do, I'm saying yes, yes. Who's the third person?
There were 2 over here.
Okay, and do you guys use anything? Okay.
I used the autofluorescence, and it was the worst hypocalcemia we ever had on a patient. And
Okay,
we don't
great.
usually have bad hypocalcemia. If we have it, it's mostly transient and was resolved with oral calcium supplementation and goes away over time. So I almost wondered if we got fooled into not just using the things that we normally do to identify the parathyroid glands.
Did you use the autofluorescence probe or the autofluorescence video mechanism?
Do you know which
Probe.
one?
Okay.
Probe, okay. Anybody used any of the other technology? Want to comment? Okay. Well, why don't we see what people are saying? It's kind of hard to read. Really split. So it looks like about a third said doing more than 25 surgeries, so high volume. a third said A plus C, which was ICG and 25. What do you think, Ben?
Yeah, I certainly agree with A, and even in our group we have 5 pediatric surgeons, and so I do all the thyroids, and even with that I don't do more than 25 a year, and so I typically will invite one of the adult thyroid surgeons who does do more than 25 a year to help assist with identifying the parathyroids and also the recurrent laryngeal nerve. And then in the literature, the autofluorescence has been shown to decrease rates in a randomized controlled trial out of France. And so transient rates are 15 to 30%. Permanent rates have been reported even up to 15%. There's a greater concern for those in pediatric patients. And so identification of the parathyroids and also preservation of their blood supply, autotransplantation, if it's at risk, can help to decrease those rates. Next slide.
Well, let's keep going. Next slide.
And so I mentioned the randomized controlled trial, but I'll talk about what was done. And so parathyroids can autofluoresce. So there's a technology system, the FluoBeam system, in addition to the probe system. And with using the FluoBeam system, they noted hypocalcemia rates that were about half with using it versus not using it. The need for autotransplantation, about a third. And then the rate of resected parathyroids in the specimen or otherwise was about a quarter. And all those were significantly different in the randomized controlled trial.
And then I would just point out the autofluorescence that works with nothing. You don't inject anything. It's just the parathyroids naturally autofluoresce at that wavelength. So it's using that technology. And then in addition, you can inject ICG, and we'll get to that later to look at the perfusion of the actual parathyroid glands.
So this just shows an example where you can see the thyroid gland lifted and exposed, and then with the autofluorescence you can see the bright areas signifying the superior and inferior parathyroids to help identify them early and then be able to separate them from the thyroid and work to preserve both them and their blood supply.
And then this is adding ICG, and we'll kind of get into some of those indications. I will agree, like we have the FluOptics machine, and like the pictures that are sort of published in the studies, like I haven't found it as nice as those pictures, but I do think it's a helpful adjunct for a few things that we'll get to. All right, I think this is me. So which of these things have been shown to correlate with normal calcium after total thyroidectomy? PTH greater than 20, PTH less than 20, high fluorescence intensity of at least one parathyroid gland, or D, A plus C. I think our questions are really easy, but we'll see what people say.
Why don't we just, for the sake of time, just
let's go to the next one.
See the poll and see how many have answered, and then looks like at least the majority are saying A and C.
Yeah.
So let's keep going.
So this study basically showed that there's no persistent hypocalcemia if you see high fluorescence of at least one parathyroid gland. Now, exactly what that means, is kind of questionable because it's somewhat subjective, I guess I would say. Let's go to the next one. It also gets tricky doing it too because you can usually see two of them at once and give the ICG and see if they perfuse. Seeing both sides at once is a little tricky, and the device itself is kind of bulky to use. So when should you consider parathyroid reimplantation? A, ICG shows poor vascularity. B, autofluorescence shows parathyroid on the thyroid specimen. C, what's reimplantation? So I guess all but 4 people in the room will pick that. And then D is A and B. Let's go to the next one and see the poll. And I will say, of all these things with the FluOptics machine, the one I find it most useful for is looking at the specimen. we've definitely, saved some parathyroid glands that we may not have seen otherwise. All right, looks like yes, most people are saying A and B. Agreed. All right, next. And this just talks about reimplantation. We can go to the next slide.
Do you think we really need to reimplant in children?
Okay, the question is, do we really need to reimplant in children? What do you think?
If you're talking about the risk of permanent hypoparathyroidism and hypocalcemia and the need for what can be very difficult to manage hypocalcemia in the setting of permanent severe hypoparathyroidism, I think you got to give them their best chance.
I guess I would kind of ask another question. Do you mean if you see it and it doesn't perfuse well, or you see it like on the specimen?
Well, so I would suggest, since I think both of those things don't work very well. So the autofluorescence and the ICG, I don't think work very well for identifying the parathyroid, and so we don't use that. And if we do happen to see a parathyroid that maybe looks like it doesn't have the best blood supply, we just stuff it back where we found it, and I think it gets blood supply from the surrounding tissue. So my question is, do you really need to put it somewhere else, or can you just leave it where it is? And is that different in children and adults, maybe considering children have a better propensity to revascularize the parathyroid?
Yeah, I think that's a good point.
That's a good question.
Something to think about. We'll keep moving. Because we've got 2 minutes. And then you want to do the conclusions and we can...
Sure. So there are a few papers out there suggesting that some emerging imaging technologies using autofluorescence and ICG angiography do hold promise to help improve identification and preservation of the glands. They can be difficult to implement, and there are varying, we mentioned the probe, the actual video, ICG versus autofluorescence, and so all of these are just beginning to be studied. And another question becomes, how do you get your center to, if it is indeed as beneficial as shown in the randomized controlled trial, when you may do 10 or less than 25 per year, how, as a pediatric center, do we advocate for our patients to have these things that at least are starting to be shown in adult trials to hold promise?
Yeah, I think those are good points. I will say, you can go to the next slide. I think it shows sort of the, keep going. Yeah, I mean, I agree that the actual real life use of it may not be as good as, advertised. It's helpful to have the reps, come do the first few to sort of show you some of the tricks, especially when you do the ICG, you have to change the sensitivity pretty quickly or everything just lights up really quickly and is not very useful.
They did just come out with a new one within the last month where there's a switch you can flip to do autofluorescence versus ICG angiography, so the ICG doesn't overwhelm the autofluorescence.
Yeah. And I think the technology will keep getting better, and it will become something that becomes, more mainstream. And then I think I think you made a good point, like, make use of the adult endocrine surgeons, limit the number of surgeons who do these, and like we have a great group for the for thyroid surgery where we have an IR person, a pathologist, radiologist, endocrinologist. We meet monthly, an ENT surgeon. It's super helpful to do that, and I think if of anything, that probably improves outcomes more than anything else.
Thank you, guys. This was awesome. And so let's hear it for these guys. That was awesome. It's all when we're picking the agenda for the update course, we always debate, do we do things that not everybody does? And we feel strongly about putting things in, even if most people don't do that operation, for exactly that reason, to make sure that people may want to start doing that and sort of getting acquainted with it. But we certainly would love to hear feedback on other topics like this for next year. We've already had one, hidradenitis, Tim gave us. All right, so this is the highly anticipated part of the event every year. I was at a conference where we had IPEG or something, and Jose Campos walked out to me and he said, "Hey, Todd, you guys do that update course." I was like, "Yeah," thinking he was going to tell me a big compliment. He's like, "Yeah, it's not very good." No, he said, "You know, you're great at talking about pediatric JPS articles. What about all of the other journals out there that are publishing really high yield, important articles that we should know about?" So for the past, how many years? 10 years? I don't know how long you've been helping us, but he's been pointing out, and if you get all the social media stuff, all the infographics come from Jose Campos and his team in Chile that point out all the key articles that we may not see every day in our core journals. So we're going to bring you guys in. We have Sean St. Peter and Jose Campos, otherwise known as Nano, to present this year's updated literature review. Do we have a thing for them too? Okay, we'll see what score you get. We'll see if you're... Is this mic working? No? Test it.
Yeah,
there you
there
go.
is.
Okay.
Thank you very much, Todd, for that kind introduction. We need to come up with a better anecdote because we've been repeating that one, the same one. I'm very happy to be here among friends. Thank you for the opportunity to be standing next to Dr. St. Peter. And I know we're running out of time, but can we get the slides, please? I just need to take a minute to thank some people. I wouldn't be here by myself. I lead a group of 30 volunteers. So last year we were 25, now we're 30. We're slowly growing. And this is a group we call Journal Hive, nested within the Surgical Society of Chile. So what we do, 3S, we screen 1,200 articles, 8 each month. Then we select based on different criteria, methodology, journal, specialty. We also included voting, so you all can vote, you all can collaborate, and then we spread the word every month with newsletter, podcast, and infographic. So all the links are going to be in the last slide, so let's just get on with it. So we picked, that's the whole group, sorry. I wish we could name everybody, but they're all there. Let's get on. So we brought 4 articles this time. We tried to make, it's still a subjective selection, but we tried to bring like a bread and butter to surgery, like the most common surgeries we do. So we're gonna talk about inguinal hernia, trauma, we're gonna talk about ovarian sparing surgery, and we're gonna repeat a little bit about the CBD stone discussion with an algorithm to predict CBD. So our first question is, you are asked to evaluate a former 29-weeker, a baby with an uncomplicated inguinal hernia, unilateral. The referring pediatrician mentions that the baby is likely to be discharged within 2 weeks. What would you recommend? Perform inguinal hernia repair before discharge? This is very common to all of us, I think. Or discharge the baby and settle an elective outpatient surgery. So while we get the poll results, I would like to ask Carlos, dear friend from Mexico, what would you do in this scenario and why?
So we would do A, especially with the population, our population, where you don't really know if the patient will come back if you schedule for another surgery. So we guarantee that the surgery is done by not letting them leave without the surgery.
Okay, cool. Anyone else? Anyone else? Does anyone?
Is there anyone that would send them home?
Oh.
You guys are crazy. Just that's all I can say.
Just like anything, it depends, right? How big is this hernia? You know, is it something that's always out? And you know it's going to be a rock fight for an hour and a half or 2 hours in the operating room, and they're otherwise fine, you know, send them home.
Easy to reduce, uncomplicated hernia. Don't make it more complicated than that.
I mean, that matters.
So I think the thought of them incarcerating before coming back is much lower than we think. I practiced in a system when I first came out of fellowship where we were regional and there were 12 other NICUs that all sent them home before we even knew they existed. They came back and followed us in clinic, and none of them had incarcerated when we waited their time, and that was over 80 patients. So I think, don't know the exact rate, but I think it is pretty low.
Great point.
The other thing, you may have a child that just weaned off of oxygen or is on 1 liter nasal cannula, and all of a sudden you're resetting the clock big time. And that's really kind of a demoralizing thing for the family, for the team, because you took them to the operating room because you felt obligated to repair. I understand in certain contexts where you may not get those patients back, of course. But again, it depends on the environment and the economy that you're sending these patients out to. If they have good follow-up, then let them go.
Yeah, I think there's a lot of complexities to this that can't be boiled down into one choice versus another. But the study that is going to be reviewed, not working? No, it's working. The study that's going to be reviewed is data that puts a nudge in one factor toward one direction, which would be the delayed repair. So we have a bunch of nurseries in the area that don't have pediatric surgeons, so they come to our clinic. So by definition, they get the delayed repair. Simultaneously, we were frequently doing repairs in our nursery, so we were doing a dichotomous practice within ourselves. And to make it clear for the fellows and the neonatologists, we just recently went to, the plan is for coming back with a delayed repair. And what you just alluded to, those kids that are just kind of coming off oxygen and just starting to find their feet, those are the ones that ended up making the big difference in that study that Marty led, because those kids that are kind of fragile, it wasn't about the hernia repair, it was about their pulmonary status.
All great points, and shows how nuanced this discussion is and how difficult must have been to put this trial together. I think, why don't we have a look at we have a short 1-minute video that's explaining the article, and then we can see if someone got convinced to change over the practice. We did not comment on the results. It was how much was it? Like 60 and 40? 50-50, yeah. Okay, let's go.
Infants, but the optimal timing for surgical repair is still debated due to associated risks. A recent European study demonstrated an important variation in practice patterns, with 56% of surgeons recommending surgery before discharge. This article, entitled Effect of Early versus Late Inguinal Hernia Repair on Serious Adverse Event Rates in Preterm Infants, a randomized clinical trial, was published in JAMA 2024. The authors assessed if the timing of inguinal hernia repair influenced the likelihood of serious adverse events in preterm infants. This study involved 338 preterm infants diagnosed with inguinal hernias before their initial hospital stay. They were randomly assigned to either early repair before NICU discharge or late repair after NICU discharge. The primary outcome measured was the occurrence of any of the predefined serious adverse events over a 10-month period, including death, hernia complications, and respiratory and cardiovascular morbidity. The study found that late repair significantly reduced the rate of serious adverse events, with only 18% in the late repair group compared to 28% in the early repair group. The late repair group also experienced a 3-day reduction in length of stay. Applying these results, delaying inguinal hernia repair until after NICU discharge might be safer for preterm infants, potentially reducing the risk of serious complications.
What? Can we go to the next slide, please? So, okay, so you're not convinced by it. So there's a well-done randomized controlled trial that showed that there's a 10% benefit. You're not convinced. Tell me why you're not convinced.
No. You always change my practice more than almost anyone else. So I just am surprised by the results. It's not that I'm not convinced. It's not what I would have expected from this paper.
Okay. But I saw a lot of hands up on the early repair group. So are those people convinced or not?
I mean, I think it was said right earlier. This is an important data point. It adds to the nuance of this discussion. And I think for many patients, waiting is the right answer. But I don't think that this data says that early repair is wrong. If you look at that table, it's mostly apnea requiring intervention. That's what the difference is, right? And so you have some kids with apnea who need some oxygen or who need a little, extra time of close monitoring. And so it's not like these are, they call them serious complications, but how serious is apnea in a premature neonate?
Yeah, so that's a great point. That this table doesn't fit in our short video, but you can see clearly that there's two profile of complications here. Like there's different complications associated with early and different complications associated with late. And I just want to bring back Steve's comment. He said like we thought inguinal hernia recurrence was such a high thing, and you know it's in this study at least it's 4% in late repair group, so it might not be such an important point.
This I think highlights one of the things I know Todd's passionate about, which is laparoscopic inguinal hernia repair. If you're putting a G-tube in and you see, like, look at the rings, it may, hopefully, if you're facile with it, it's an extra 5 or 10 minutes to get those things repaired. And then, yeah, it's a big, I mean, but if you're there anyway, and you've got to be there because that is the next thing that child needs to ultimately be discharged, then yeah, early repair, go for it. Don't spend 5 hours doing it.
But you also bring up a very good point, is that this was designed in the open era. So part of what we talked about, and this started with a conversation we had at PAPS in 2011 when Marty had this passion to start the now later. That's how long it takes to get this kind of work done. So congratulations to that group for having done it. But it started around the auspice of how difficult that is in the hospital with an open operation. Yes. And then within 2 years, we had gone completely over to laparoscopy. So we were thinking, well, that question really doesn't need to be answered anymore because it's a different one than what we were asking in the first place, which is how difficult the open operation is. It ended up turning out that it didn't matter if it was open or lab because it was all driven by respiratory complications, and that was the difference. So now the point is just let them grow up a little bit unless there's any other mitigating factor that would say, let's just do it now. Like a lap G-tube, like they're 3 hours away, like Carlos said, they're not going to come back.
Interesting discussion. Should we just keep going?
Yeah, keep going.
I think we're running late, isn't it? So second audience poll. You are the trauma surgeon on call. The emergency department has just received a 70-year-old boy involved in a car collision at 100 kilometers per hour, or 60 miles per hour, with a rollover. The boy is currently clinical stable with a normal physical exam. What would you recommend? A, admit for observation, discharge from ED, or C, perform a CT scan? Can I get Regan Williams' opinion, who just gave us a beautiful article on abstract recommendations for
Wait,
bronch
is she
trauma?
going to give the answer, though?
I just want her opinion. There's no answer. There's no answer, Todd.
Talk kind of slow so you don't give it away. Yeah, go ahead.
So I think there are a lot of options depending on where you are. But our current data would say for a patient like this, you probably don't need to get a CT scan. You can observe them and maybe even discharge them from the ED if your situation allows that, going back to what you said about hernias.
Can I get some hands raised? Who would have CT this patient?
No.
No?
No.
Okay.
So I have a bigger question is there are many trauma guidelines that make something a level 1 or a level 2. There are historical elements, meaning the history of the patient and the trauma. How many things should we be reevaluating that the actual history of what happened should be impacting how we take care of those patients? The mechanism of injury, all those things. We've done studies. There's a Nexus trial and others that have looked at speed of the, were there deaths in the car? Were there all these things that should guide us on how we take care of the trauma patient? And as we're getting better, I wonder at some point we should relook. Maybe that's what you're going to talk about.
No.
I want to know what the Nexus trial is, Todd.
Oh, shit.
I'm just tossing that one out there.
That's the C-spine trial, right?
That is
That's
the
the
C-spine
one
trial
that said
in adults.
Oh, and it doesn't apply to kids? Because I've been using it.
There's a new, actually, we'll put that on the list for next year. There's a really good new PCARN study for the cervical spine.
But that was at that time, was the largest clinical trial, at least for trauma, that's where it looked at mechanism of injury and all those things that talked about indications on when to get a C-spine. And that was the first big, large, why are you laughing at me? What did I say wrong?
No, I loved it. I loved you.
You know how
talking about
insecure
the
I am with
Nexus
trauma
trial.
data. Why are you making?
No, it's awesome. You're so right. You're so right. I was curious if Dr. Williams would get labs on that patient because that wasn't an option.
I would absolutely get labs before I made a decision about getting a CT scan.
My question is, do you think that the imaging or workup is different if this patient presents at an adult trauma hospital with pediatric accommodations versus a true pediatric trauma center?
Great questions. I do not know the answer to that. Can we see some poll results? Or Dan wants to answer that.
There's actually a question in the chat about the use of FAST. As a non-fast advocate, I just would be curious as to what's your answer on that.
Great question. So again, I'm not a trauma expert. I would rely on Regan's opinion on this, but I think FAST is an algorithm based on adult experience, and actually in children it has a lot of negative false positives and false negatives. So if you're using ultrasound as a scope to make your better assessment and get more info and to make a clinical assessment, I would say yes, but using FAST as kind of the streamlined algorithm that it is in adults, I would not apply that to children personally.
You are exactly correct.
Boom.
Amen.
Okay, did we get some poll results or not? So most would admit for observation, and 40% would do a CT scan, just like I would. Can we see the video? So I'm happy that, Katie, you brought the pay-current group, because that's exactly what we're highlighting today, the pay-current group.
CT scans are frequently used in pediatric abdominal and head trauma, and many times overused, exposing children to an unnecessary risk of radiation-induced malignancies. The article titled Precurrent Prediction Rules of CT Imaging of Children Presented to the Emergency Department with Blunt Abdominal or Minor Head Trauma, a multi-center prospective validation study, was published in the Lancet Child and Adolescent Health in May 2024. The authors asked themselves whether the Precurrent prediction rules accurately identify children at very low risk for serious injuries, thus reducing unnecessary CT scans in pediatric emergency departments. This prospective multi-center study enrolled 27,541 children under 18 years old who presented with blunt abdominal or minor head trauma across 6 U.S. pediatric centers. The study evaluated the Precurrent clinical prediction tool before the decision of obtaining a CT, admission, or any other intervention. The primary outcomes measured were intra-abdominal injuries requiring acute intervention and clinically important traumatic brain injuries. The Precurrent prediction rules demonstrated a sensitivity of 100% and a negative predictive value of 100% for identifying both. One limitation of the study is that the Precurrent rules were already known by the physicians applying them by previous retrospective studies, so they could have been already applying them. Implementing the Precurrent prediction rules in pediatric emergency department could help clinicians avoid up to 25% of abdominal CT scans and 15% of brain CT scans, thereby reducing radiation exposure and improving the overall quality of care for children with blunt abdominal or minor head trauma.
Okay, so we're not saying, of course, that CT or imaging doesn't have a role in trauma. I apologize for this super busy slide. I hate slides like this, but it just mentions the inclusion criteria for the pay-current and the pay-current rule. And actually, it's been shortened because the head part of it, it's slightly different under the 2-year and above the 2-year mark. I think the bottom line is that in most cases, you don't need a CT, but the high quality of this article just brings the reassurance for the clinician, in which cases you have a 0% chance of having an intra-abdominal injury requiring intervention, and therefore no need for a CT. Dr. St. Peter?
No symptoms and no physical findings. The chances of three-dimensional imaging changing your management is pretty slim.
I mean, it doesn't surprise. We keep finding that more and more now, that the history and the mechanism should not be considered as much as we thought historically.
Yeah, I know we say here, like, yeah, I don't find it surprising. I am very happy for this audience, this present audience, just to be so on the top of their game that they're not gonna scan. But you know, the poll audience, the 3,000 people at home, 40% of them would CT in this case. So I think this articles, it is relevant worldwide, I think. Or at least for me, I learned a lot from it. Anyway, let's go to scenario number 3. Or does anyone want to comment anything else? Let's roll. So you are scheduling a cholecystectomy after an ultrasound diagnosis. Do you routinely order any of the follow-up tests pre-op to assess the risk of a common bile duct stone? So this overlaps a little bit with Luke's, Neff, and team presentation. Who can give me their opinion while we wait for the poll results? Oh, Miguel, you want to say? Okay, you do know I rely on clinical factors and ultrasound.
Hey.
And can you elaborate on that, please? Like how?
If the patient has just came to the ED with colic pain and had an ultrasound and everything was perfectly well, just stones in the gallbladder, no other previous history, the labs were normal at that time, I shouldn't do anything else than just go to surgery at all.
And how many times have you been surprised by performing the lab chole and finding dilated bile duct, finding a stone, not knowing what to do, or maybe not in your case, sorry, but being challenged by the situation?
Knows what to do.
No, I call Todd.
You call Todd. Okay, let's go. So how many times have you been in the situation in which you just rely on clinical factors and ultrasound, and then boom, I'm in a difficult situation, I don't have, not talking about you, Todd, but don't have the skills or the equipment to resolve? How many times? Slim?
Very.
Very rarely.
Yeah.
Okay, can we get some poll results? Okay, please.
Yeah.
But wait, is the question that the patient had an ultrasound and normal labs, or had an ultrasound with no labs?
No, you have patient, ultrasound, nothing else.
Okay.
Miguel
said that the labs from the emergency room were normal. So those are two different situations.
No, it says C, yes, I order liver function tests. Do you order liver function tests before? So symptomatic, you wouldn't. Clinical factors, ultrasound. What would be your choice?
I did C.
You did C.
Yeah, so I think going into this without any preoperative risk factors, you need to know. You need to know. You have to have an ultrasound. You have to have labs. I think those are straightforward things to do. You can put a patient in a very, very low risk category if they have a normal ultrasound, normal labs. In fact, most guidelines would suggest then you don't even need to do an intraoperative cholangiogram. You can just take the gallbladder out. And those by themselves, just getting that preoperatively is going to help you risk stratify the patient.
I think that's a segue to the prediction model. Why don't we talk about the prediction model, and then we'll give the upshot of the last one.
Jose, I lied to you. They want us to wrap up.
Okay, sorry.
These are so critical, so just give the high yield points. Yeah.
Let's go to the video then.
Pediatric cholelithiasis is becoming increasingly common due to the rising obesity rates among children and adolescents. Unobstructed common bile duct stone can be found in up to 30% of pediatric patients with cholelithiasis during surgery. Making a timely diagnosis of common bile duct stone can be critical for improving patient outcome. The article titled Machine Learning to Predict Pediatric Cholelithiasis, a Western Pediatric Surgery Research Consortium retrospective study was published in Surgery in 2023. The authors evaluated if a machine learning model could accurately predict pediatric cholelithiasis using clinical and laboratory data. This retrospective cohort study included 1,597 pediatric patients who underwent cholecystectomy across 10 institutions between 2016 and 2019. An extra trees machine learning algorithm was used to evaluate 9 clinical features, including age, BMI, and specific lab values, to predict the presence of cholelithiasis. The machine learning model demonstrated high accuracy with an area under the receiver operating characteristic curve AUDA of 0.95 and a negative predictive value of 98%, significantly outperforming previous prediction models. A limitation of the study is the reliance on the retrospective data, which could introduce bias and affect generalizability of the model. Also, machine learning is a novel technology for the medical field. Implementing this machine learning model in clinical practice could improve the accuracy of diagnosing cholelithiasis preoperatively in children and improving patient selection and resource organization and use. It could also reduce the need for invasive procedures and unnecessary imaging.
Cool. The key point is that you can actually risk stratify patients with a lot of certainty, and I think comparing this to other models, this is the best we got.
This is is awesome. Give me, what's the high yield point of the last one?
Point of the last one is it's about ovarian sparing surgery in benign tumors, and by actually getting together with your team, with radiologist, oncologist, adolescent, OBGYN, you can actually develop a algorithm to reduce your unnecessary oophorectomy rate from, you can have it in this scenario from 16 to 8%. And you pointed out a really good point about this article. Can you share it with the audience about the Hawthorne effect and stuff?
Oh, I was saying that some of this was the Hawthorne effect because this was put into place and then we measured it going forward. So places who were already having multidisciplinary conversations were still going to have those. But you had to basically check the box once you had a consultation that you talked to the gynecologist, and then once you had a chance to have that mutual conversation, you always had a game plan that very rarely led to oophorectomy.
So I learned about the Hawthorne effect after Dr. St. Peter's commentary. I had no idea. But anyway, if it's the Hawthorne effect, it's not kind of a real surgical difference. It's still replicable. So even if it's the Hawthorne effect, someone published it, and you could do it too. That's it.
Just get your gynecologist on the phone.
Yeah. Any final comments? We're going to break for a little bit. I know we're about 10 minutes behind. We'll make it up during the break, so that means everybody here has to eat fast. Any comments or questions on all the stuff you just heard? Yeah.
I have one regarding the machine learning model. I think there's going to be we have to be prepared for these machine learning models because there's going to be a huge slew or a huge wave of these models that work in a great manner. But we as pediatric surgeons have to define how we'll approach it and how we'll use it, because we know these machine learning models work with the population that they were trained at, but how will we apply them to our population?
Yeah, we were just talking about that yesterday. Katie Russell is one of the co-authors of that, isn't it? Yeah, and they're moving forward to do a prospective validation, and also Luke Neff, I think it's involved in that, and they're looking to broaden the validation population. So I think that's an excellent point you've made.
Thank you.
Any other comments, questions? That was a lot. You guys can see why we value your team so much, because it opened our eyes to studies we normally would not see because we keep reading the same journals. So thank you for continuing to do this and doing it all year round. Your work's incredible. Thank you so much. So congrats to you for doing that. Thank you. All right, we are going to break for how long? What time are we coming back? 12:30. In 20 minutes? Okay.
I got a call from his pediatrician. He just said, I am so sorry, but there's a very large tumor in Atticus's brain. We would go to the ends of the earth for our child, and it was the obvious decision to take him to Cincinnati Children's for his cancer care. It required us to travel from Nashville to Cincinnati. Cincinnati Children's is the one that helped save Atticus's life, and we are so thankful.
I get to ask the kids beforehand or the family beforehand if they have a particular interest, a cartoon or sports or something. Do we come up with
What do you want your bandage to be?
The Flash running through.
The Flash?
Mm-hmm.
Cool, like Flash, like the cartoon Flash?
Or something with lightning.
Okay, something with lightning, done deal. At the end of a case, as everyone's kind of finishing up, I'm not hovering over everybody. I can help make this dressing kind of thing. And everybody kind of gets into it. I have a whole set of pens and pencils and stuff, and we make these things. But basically, every child I've operated on, 10,000 or whatever, have gotten a unique dressing. I have fun doing it. Kids love it. Parents love it. I had one, the dad was, it was a Brownie the elf, and the dad loved it so much that he couldn't take it off. He's trying not to ask, but basically he's like, can you cut out another one from you. So if I would, I had to cut out another Brownie the Elf for him. And I wouldn't call myself an artist. I totally do enjoy doing some creative things. I do draw, paint a little bit, but I like to feel like I'm giving them something that I've, spent some time on to tell them you're not just something I've operated on. You're actually a human being, and here's a little piece of me with it. It's all really good.
When you're operating on a baby, you're impacting the rest of their life. So if things don't go well or you have problems, it could affect the rest of their life and how they develop and grow and go out into the world. So to have the right size tools that are finely crafted and are surgically precise is incredibly important. Without those tools, it would be incredibly difficult, if not impossible, to do it. Dr. Stortz, Sybil Stortz, had an incredible commitment to the children of the world, and she invested huge amounts of time and money to help develop the instrumentation and to do the training that we needed to train pediatric surgeons all over the world. And I think that commitment stands for a lot. It is a pediatric portfolio. It goes the entire spectrum of pediatric subspecialty care. So it's a total solution.
Some said Tiago had 1 week to live, but this resilient, cancer-free kid had other plans. Through research, compassionate care, and support from people like you, Seattle Children's is fighting for lasting cures. So to every kid that didn't have a chance, this relentless fight is for you. Because this isn't about beating the odds, it's about changing them for all kidkind. Hope, care, cure. Seattle Children's.
We like to use a NIM tube. That's part of trying to prevent potential injury to recurrent nerves, or at least make you aware when you're getting close to them. It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Now that we understand the standard workup and OR setup, let's dive into the typical approach of Dr. Dialarcon's team.
It's a standard neck approach where we raise subplatysmal flaps. You deal with the anterior compression as needed.
Sometimes they can assist with the thoracoscopic approach by removing some of the residual or regrown large thymus because it's right in the way.
Did you know that State Current has an entire video library on surgical technique videos? Today, we are highlighting a laparoscopic orchiopexy. Today, we are highlighting a thoracoscopic repair of a Boschel-like hernia.
Hey, there you are. I just got the call. 5-year-old male pulled from a house fire. Vitals are listed here. What should we do first? All right, airway's intact. Breath sounds are equal and present bilaterally.
For this issue, we talked to Dr. Colin Martin. He is the publication chair and the editor of this issue.
In this case, it was very obviously, and it was seen on ultrasound, that there was no septum and that there was a huge cyst.
pediatric surgery. So here's another article that you probably want to know about.
The authors here wanted to take a look at preventive fundoplication for patients undergoing repair for a congenital diaphragmatic hernia.
We don't have much time, so let's start.
In this study, the authors reviewed their experience with laparoscopic common bile duct exploration with balloon sphincteroplasty for patients with pediatric choledocholithiasis. This was a retrospective review at their institution between 2018 and 2021.
For more than 65 years, Oishei Children's Hospital has specialized in the surgical care of newborns, children, adolescents, and young adults. Oishei is the only hospital in Western New York with 24/7 access to pediatric surgical subspecialties.
That includes pediatric plastic surgery, ENT surgery, ophthalmology surgery, oral maxillofacial surgery and pediatric dentistry, general surgery, thoracic surgery, orthopedic surgery, neurosurgery, and pediatric urology.
We treat all children for most common problems, such as trauma. Cancer is a problem, but we provide a full sort of spectrum of care for that. Birth is a happy occasion, but sometimes some babies are born with challenges, and we help to fix that. And then there are other things, common things like appendix hernias and so on, other things that we do.